Good afternoon.
Good afternoon, Madam Chair.
Good afternoon, committee. We are the Senate Finance Committee, and this is our first bill hearing of the 2023 session. Today is Tuesday, January 31st, 2023. I thought since this is our first bill hearing, I wanted to first acknowledge the members of the Finance Committee, and so for those that are here, we want to just acknowledge them very briefly as this is our first meeting of the session where we'll be hearing legislative introductions from our colleagues. And so to my left, we have Senator Ellis, who comes from the southern part of our state, Senator Reedy. We have Senator Kramer. To my left, we have the Vice Chair of the committee, Senator Klossmeyer. To my right, Senator Hershey, Senator Beidel, and Senator Guile. And I will tell the audience, we do have other members that are presenting bills in other committees, so you may see people going in and out throughout the hearing. It's not a lack of attention to the subject matter you're presenting. They may have bills that they're presenting in other policy or budget committees. Today, we're going to hear 7 pieces of legislation in the following order. We're going to start with Senator Augustine, who will present Senate Bill 8, Senate Bill 14, and Senate Bill 101. Then we'll move to Senate Bill 125, Senate Bill 38, Senate Bill 78, and Senate Bill 64. We have 7 bills. We have witnesses signed up on each of those bills that will give testimony in person and some virtually. To the audience, I know you've been reminded to turn off your cell phone bills and cell phone, not bills, your actual cell phones. I'd like to turn off my cell phone bill, but if you can turn off your cell phones, because we will be interacting with virtual witnesses, and that helps us with this process. Also, to let the witnesses know, we will have sponsors present the bills, and then the witnesses will be on a 2-minute timer. So we ask that you keep your remarks concise, your presentations concise, so that we can get through our business for the day. But we do want to hear from you, and thank you each for coming and being a part of this process. We will also provide opportunity at the end of the panel for members to raise questions. Are there any questions from the committee? Okay, and I also want to acknowledge we've been joined by Senator Hayes. Good afternoon. All right. So with that, we want to thank the phenomenal staff of the Senate Finance Committee and all who support our work. Everybody wave, and we'll get started with our first bill. So Senator Augustine will be hearing Senate Bill 8, which is mental health treatment plans for individuals in facilities requirements. And you can bring your panel up with you if you like.
Thank you, Madam Chair. Is Ms. Stokes-Hammond here and Ms. Yasnow? You here? Please. All right. Madam Chair, Madam Vice Chair, members of the Senate Finance Committee, y'all are fine right there. Senator Malcolm Augustine here, asking a favorable report on Senate Bill 8, treatment plans for individuals in facilities. It's good to be here with you all here in Senate Finance, and it's just good to see you all. And you all know very well from my time in this committee that behavioral health is something that is just, I think, is just a really important issue. And that's what this bill is. This bill actually also kind of gets to some of the things where the challenges that are associated with making sure that we protect people's individual liberties while also trying to make sure that people are able to get the best possible care that they can for them. And that's a balancing act that we often have to try to work on in here as far as trying to manage those two things. And this bill seeks to try to actually do something about that when someone is already in a facility and are receiving treatment. And so what Senate Bill 8 does is it requires a plan of treatment for individuals with a mental disorder admitted to a healthcare facility to make sure that include a long-range discharge goal and an estimate of the probable length of the inpatient stay. so that make sure that individuals are required to be transferred to a less restrictive or intensive setting. It also requires the staff who work directly with an individual to review and reassess that treatment plan to determine the individual's progress and any need for adjustments that might occur in a certain period of time. It also asks that a individual if they consent to the inclusion of family members or any other individuals, that they be included in that process of the plan for the treatment, which is really central to this bill. That's really, really central to this bill. It also says that if an individual agrees, the facility will include authorized individuals in each stage of that treatment plan and provide notice to authorized individuals for treatment, meeting at least 7 days in advance if it's being held due to an emergency as soon as the meeting is scheduled. This also, the bill also believes that treatment is not meeting the needs of the individual or an authorized individual has the right to request that the facility review and reassess the plan of treatment. And then if an individual admitted to a state facility, if that treatment is not going the way that you would expect it to go, that then that individual would have the ability to request an administrative hearing for reconsideration of review and reassessment with the chief executive, who shall then forward that request to the Office of Administrative Hearings, who would then conduct a hearing and issue a decision. Now, this is trying to deal with situations which you'll hear from the witnesses where, as I mentioned earlier, you've got someone who's in there, there's not necessarily agreement on the plan going forward, or the individual may not be in a place at some point to really be helpful. The patient may not be in a position to be as helpful when this is happening. So if the administrative law determines the facility is unable to provide that treatment that's necessary for the individual, the judge will have the ability to order that the facility to make arrangements for individuals to receive treatment from another facility, ensure the treatment is coordinated between both facilities. And know that the judges already, particularly when you have someone who is being admitted or committed to receive these types of services, our judges are already involved in that process. So this is not like this is something that they don't do already. It is something actually that they do. They have to participate in this process as it stands today. Senate Bill 8 provides vital provisions to the existing policy for treatment plans for individuals with mental disorder that are admitted to a facility through the establishment of these requirements for facility staff to review and reassess the treatment plan. And Senate Bill, it also works to make sure that we're working when there's a discharges, make sure that we have the much more efficient discharges, trying to get people the care that they need and get them to be able to move on with their lives as soon as possible. I will tell you all that there has been, and you'll see in the testimony, a significant amount of feedback from different stakeholders about things that I know we will have to work through and work out. I'm happy to do that with this bill. But the heart of this bill really is to allow family members to be able to participate and to help their loved ones when they are not able to help themselves. If I can just kind of leave you all with that, that's really what this bill is here to do. We have to work through some of the details about how we're able to increase the opportunity for family members to do that. But with that, I'm going to ask for a favorable report on Senate Bill 8. And Madam Chair?
Thank you. You can proceed with your panel.
Okay,
Senator.
thank you, Madam Chair. So first we'll hear from Ms. Shelley Stokes-Hammond.
Thank you. Good afternoon, Chairwoman Griffith, Vice Chair Krausmeyer, and Senate Finance Committee members, Senator Augustine. My name is Shelley Stokes. I have lived in Silver Spring, Montgomery County, Maryland, District 18 for 5 decades. I'm here to testify today on behalf of Senate Bill 8. I am the mother of 3 sons whom I love and am proud of, who grew up in Montgomery County. This bill could help my youngest son, who is 27, and many others. My oldest son, Brett Hammond, has submitted written testimony on his brother's behalf. It's difficult to come before you today to discuss such a sensitive family matter, but I was raised by a family that believes in and has served our country in legislative, legal, judicial, and medical capacities. But this time, I sit here today reaching out to you on behalf of your ability as legislators. I tried staying under the radar, My family member worked diligently and complied with treatment. However, complexities with treatment led to new and worse problems. We were in the process of seeking help from specialists at NIH, McLean Hospitals, and others when an incident occurred and landed my son in a state hospital. Today, a call to 988 instead of 911 probably would have resulted in a different outcome. Once in state hospitals, more complications arose. It was challenging to have a seat or a meaningful voice at the treatment table, although my family member had given his consent and I had power of attorney. We were not permitted to engage consultants until guardianship was approved. Guardianship was very costly, to the tune of about $12,000. So far, taxpayers have paid $1 million for my son's treatment. When the risk to my family member's health, life, and future became greater than the embarrassment of the trifecta stigma of race, mental illness, and criminal justice, I realized I had no other choice but to reach out to people like you for help. So today, I thank you for considering this important and necessary piece of legislation.
Yep.
Good afternoon. My name is Robin Yasino. I'm a volunteer mental health advocate in Montgomery County. I live in Rockville in District 17. Thank you for the chance to testify in favor of Senate Bill 8. There are people that I've met through my work with NAMI, the National Alliance on Mental Illness, and other groups who can't share their stories today. They fear retaliation. They fear that if they tell you about their experiences, things will only get worse for their family members who are in psychiatric facilities. That's why I'm here. I want to share a bit about my experience with psychiatric institutions, but first I want to speak this truth. Mental health care is health care. And there are rights that we all have at any facility, any healthcare facility, no matter what condition we have. One of these rights is to be included in the development of our treatment plans and to involve a trusted family member or a friend if we choose to. This isn't just about being respectful, it makes economic sense. Involving patients and the people who love them in treatment plans leads to faster recovery and lower rates of readmission. Studies show this, and I know this to be true from my own life. When my loved one needed psychiatric care, our family was highly involved with that treatment team. And when we faced a relapse, we were able to avoid sending my loved one back to the hospital because of that level of engagement. In contrast to that good experience, I remember one of my own stays in a psychiatric facility when my treatment plan was a complete mystery to me and my family. We came to find out that there was no plan. It still feels a little bit like maybe they just didn't care. But I was comparatively fortunate. I got out. Too many people, especially ones at forensic facilities, are stuck. They spend their days languishing in hallways. Every person who goes into a facility deserves a full life outside of one. Please, I urge a favorable review of Senate Bill 8.
Thank you very much. Colleagues, are there any questions for this panel? Senator Hershey.
Thank you, Madam Chair. Senator, great to see you back in Senate Finance.
See you.
We certainly miss you. Quick question. There's, as you mentioned, there's obviously a number of letters of concern, and your words, legislation does need a little bit of work. My question involved the testimony of a couple of the psychiatric societies, and they talked about involuntary commitment rather than, I think the stories seem to be a little bit more, I don't know the stories, but maybe it is different from a voluntary commitment, where I certainly respect what you're trying to do and get families more involved and protect some of those liberties. But if we're looking at involuntary commitment, do we really want the families to have that much say in the treatment plans and potentially, as they're writing, veto power over the treatment plans? How do you work out the difference between a voluntary and involuntary admittance?
Senator, I would be happy to look at it more closely. But what I would say, though, is that even the involuntary commitments and the treatment plans that are associated with that, I mean, you want the folks, the person, the patient, to follow the plan, and they need help to do that. Oftentimes, it's the family members who are able to help with that, or to identify where there might be some gaps in what's being proposed, and to make sure that people stay with it. But I understand what you're asking, and I definitely, this is not seeking to supersede the judgment of a court. If a court does that, it's just trying to provide an opportunity for family members to have a more active role and to be able to be sort of, to have that role in this process. So I'm more than happy. I'm going to check into it. I'll check on it.
I appreciate that,
Yep.
Senator. Thank you very much, Madam Chair.
Thank you. Senator Lamb.
Yeah, and thank you, Madam Chair. And to follow up on Senator Hershey's question, it looks like the department did submit testimony on this bill, and they submitted a letter of concern, I guess. And I'd like to hear the sponsors kind of, response to this, which is, in summary, they were concerned that that family members may be able to overrule some of the decisions that are being developed by the licensed clinical providers and other professionals about the individual being treated. And they also contend that there is a ability for an individual to file an appeal with the Office of Administrative Hearings. And I'm just curious to hear what the sponsor or others on the panel, why that may be insufficient from your
You
perspective.
all want to answer? Go ahead.
Thank you for the question, and I appreciate the concerns. We're not really saying that a family member should have the sole authority in making a decision about the treatment of a loved one. We are asking for the opportunity to work with professionals on behalf of the family member. That's something that's routine, whether you're trying to solve a medical problem for your heart, or asthma, or allergies. It's just having a seat at the table and offering the benefit of, in the case of my son, 23 years of his life, 13 years free of mental illness, and the last 10 years being very involved in the process to the point where we were getting the support of other doctors to try to get him to NIH. When you can't have any opportunity at all to contribute that history or to have access to that level of expert care, then the life of your loved one is at risk under the fear of a family member having the power to decide how to treat one when a family member knows they do not have the training of being a medical doctor necessarily.
And Senator, to thank you for that. I would also say that I'm clearly open, happy to work with you on particularly the appeal process portion. I mean, there was some concern. I've talked to the Department of Health about that. And so we can absolutely take a look at that portion of it. And I'm also happy to look at basically the spirit, which is what she just shared, which is that folks be able to participate and have that ability to participate, and perhaps, not necessarily overrule in the way that you just expressed it. So I think that we should look into that. But we're trying to get to what these loved ones have said. And so willing to work with the folks to try to fix the language or try to fix that to be able to do just that.
And I would presume that the reason you're bringing this bill forward is because you feel like without this in statute, families and others would not have the ability to be able to weigh in or be
Exactly,
part
they
of that
haven't been
process.
able to, so that's been their story. Their story is that they've had to be there and be shut out while they have to watch their loved ones suffer. That's the issue. That's the crux of the issue. You're watching your loved ones suffer, and you're powerless because the way that the law is written, the way that it is now, they can't they're not able to participate in this plan when their loved one may not be able to make the best decisions even for themselves. We know we have these situations, but they're able to support them, and that's the situation that we're trying to help out here.
Okay, thank you.
Yes.
May I?
It's up to the chair. She might be all,
Thank you, Senator.
yeah, okay?
All right. Senator Augustine, thank you so much. And to the witnesses, thank you so much for your testimony and for sharing your story. I know sometimes it's difficult to do, so thank you for sharing that.
Thank you for the opportunity.
Thank you.
All right, we do have Rodney Coster signed up and Brett Hammond. Are either of them here? Okay, I'm not, Rodney Coster or Brett Hammond? Seeing neither of them, Senator, we'll move on to the virtual witnesses.
Yes.
We have
Oh,
two
yeah.
virtual witnesses that are signed up to present on the bill. Colleagues, your witness is appearing on your screen, and we have Jessica Spiegel. Good afternoon, welcome.
Good afternoon. Thank you to the members of the Finance Committee, and thank you to Senator Augustine for introducing this bill. My name's Jessica Spiegel, and I'm a clinical social worker with the Mental Health Division of the Office of the Public Defender. In my role at OPD, I assist our attorneys in representing clients who are hospitalized due to a psychiatric illness. Prior to my role at OPD, I worked in a state hospital as a social worker on a treatment team providing patient care. Patients in state hospitals are often waiting for specific treatment that has been identified by their treatment team as necessary in order to move towards release from the hospital. It's common for these patients to be on wait lists indefinitely for these recommended treatments, such as individual therapy and substance abuse counseling. This bill would ensure that patients receive their recommended treatment, whether that's provided by the hospital or an outside entity, just like when patients need medical care that cannot be provided at the hospital. The lack of timely treatment for our clients can be harmful for their long-term recovery and further delays their release back into the community. Currently, there is no remedy for our clients who are stuck in the hospital under these conditions. We urge a favorable report on this bill and hope it will motivate the Department of Health to resolve their longstanding staffing issues and other factors that prevent our clients from receiving the treatment they need. Thank you.
Thank you. Any questions for this witness? Ms. Spiegel? All right, thank you very much for your testimony. We're going to move to Brad Hershey. Good afternoon.
Good afternoon. Thank you, Chairman. Thank you, members of the committee. I don't want to take up too much of your time. You've already heard from Ms. Spiegel. But I would just like to remind the committee that the provision regarding the judicial review by the Office of Administrative Hearings on this bill is only reserved to the state psychiatric facilities, not to the private facilities. And the reviews would be conducted for patients who are seeking additional methods of treatment. So these are patients who are asking for more than what the department is giving them because they feel that that's what they need to be better. I'd like to share with you very briefly a letter that I received just last Tuesday, and only a couple sentences from it because I don't want to waste your time. But last Tuesday, I received a letter from a patient at a Maryland psychiatric facility, a state facility, where he said it has been 15 months since my return to the hospital for additional treatment. I am still awaiting the substance abuse course, and I have had no individual therapy in that time. That's unacceptable. And the only way that we're going to be able to fix something like that is through something like this bill. And I would urge the committee to give it a favorable report and demand that the department be accountable for the treatment that they provide and provide the necessary treatment so that Maryland citizens can get better in the hopes that they may someday be released from a state facility. Thank you.
Thank you very much for your testimony. Are there any questions for this witness? Okay, seeing none, that concludes the bill hearing. Thank you all and have a good afternoon. Colleagues, we're now going to invite back to the table someone who is no stranger to this committee or to this table, Senator Augustine, who will now present Senate Bill 14. Good afternoon again, colleague.
Thank you, Madam Chair. I do believe that Mark Donovan is here. Yep. Right? And then Ms. Laura Berg, who I think you're here for questions. Is that correct? Okay, yeah. All right. Thank you, Madam Chair, Madam Vice Chair, members of the committee. Senator Augustine here, Senate Bill 14. Senate Bill 14 is a health occupations bill, clinical and graduate alcohol and drug counselor licensure. And what this bill does is it alters the educational requirements that individuals must meet to be licensed as clinical or graduate alcohol and drug counselors, and generally relating to clinical and graduate alcohol and drug counselor standards. What this really is doing is the bill makes it such that we have consistent licensure requirements across the board of professional counselors and therapists, where right now it's not as consistent as it should be. Now, you should know this bill was crafted with the help and support of the Maryland Department of Health Board of Professional Counselors and Therapists. They're in support of that. They're going to share with you more about the rationale for the piece of legislation, and I ask for a favorable report on Senate Bill 14. You're good, just talk.
It's on? Oh, hi, my name is Mark Donovan. I'm a licensed therapist. I'm an LCADC myself. I'm also on the Board of Professional Counselors, as well as the chair of the Substance Abuse Committee that asked to rewrite these. We made this change in order to move the requirements for addictions counselors from statute to regulation, as has been already done with the LMFT and the LCPCs in the other regulations of the numbers that we regulate. The other piece is that the LGADC had a lesser requirement for licensure than the other LGs, the LCPCs and the LGMFTs, and we wanted to raise that requirement as well to match the other requirements for licensure with the board.
That's it.
And that's all I have to say.
Yeah.
Very well said, thank you.
That's the bill.
Very straightforward.
All right. And ma'am, you're here for questions?
Yeah, just questions.
Oh, fantastic. Are there any questions for the sponsor of this panel? Senator Ellis.
Thank you, Madam Chair, and thank you, Senator Augustine, for this bill. And so, to witness, so you used a lot of acronyms there, and you lost me. I couldn't look it up quick enough, and so could you just kind of break it down again for me, because I really, it's a great bill, I want to understand what you're saying. So could you break it down without the acronyms in a few, like 30 seconds?
Yes, sir, I apologize.
Okay, no problem.
I'm an LCADC, which is a licensed clinical alcohol and drug counselor. The C stands for clinical, being an experienced counselor that can diagnose and treat. An LG is a graduate counselor. And so I talked about the LGADC, which is a licensed graduate alcohol and drug counselor. And the changes in this regulation, this statute is being made to those licenses. While you're still licensed as a graduate, you work under supervision of an approved supervisor who is an LC. Again, the regulations for the addictions counselors, the LGADC and the LCADC, are not in line with those of licensed counselors, LCPCs, or licensed graduate professional counselors, LGPCs, as well as it's also not in line with the LMFTs, which are marriage and family therapists, or the LCPATs, which is a licensed clinical art therapist.
Okay, great,
Sorry,
thank
lots
you.
of-
Easier,
sorry
but
Right.
thank
I
you.
should have brought a
Appreciate that.
diagram.
Yeah, thanks.
Thank you, Senator. We'll have Senator Reedy, then Senator Mounts.
I'm glad you're able to help my colleague, because I followed all of that before you redid it. So I totally understood it, but no. So just to summarize, this bill is going to make it easier for us to have more of these counselors, correct?
It is. It also allows us to, sorry, I didn't mention, it allows us to correct some of the wording. So, for example, in the past, we used to call things dual diagnosis when somebody had both a mental health issue and a substance abuse issue, which, by the way, occurs about 60% of the time. We now use the term co-occurring. And so to be able to change those without coming back before you and wasting your time, to just be able to change that language brings
That's
us up
great.
to date.
I'm a big fan of well, we've been doing a lot on licensing reform over the years, and
Yes,
it's
sir.
a great, I mean, I think we need more counselors, so
Yes, sir.
there's no reason some of these things we're removing make sense to me, that you still have people that have to get some professional qualifications, but it's removing some of the cumbersomeness of the process, so I think it's a good bill, isn't that so? Okay, thank you.
Thank you, sir. Thank you very much.
Thank you, Senator. Senator Mounts.
Thank you, Chair, but my question was just asked, so I just want to make sure. So anybody that's providing counseling currently would still be able to provide counseling.
Yes, sir.
When this is enacted.
Yes, we will not lose anybody in this process.
Good-
And in
good
fact,
question.
the requirements will remain much the same with, again, the change of some of the words.
And it's fair to say that some people that are providing counseling would have to get additional training before they, or is that, I'm getting into the weeds on it.
Not so much more than is already required. So
Okay.
as a master's counselor, I'm required to have 60 credits. It's going to have the same number of credits and typically the same classes.
And the count-
Not exactly the same between the different licenses.
Yeah, and the Counseling Association, I checked the testimony quickly, they all support this, correct?
That's correct.
Yeah.
Yes,
Thank you.
sir.
Thank you, Senator. I see no other questions for this panel, so thank you to the sponsor and to the witnesses. Thank you for being here. We do have one witness who's joined us virtually in support
Thanks,
of the bill. So we're going to turn to Lynn Nash. Good afternoon. Can you unmute, ma'am? If you could unmute for us? Perfect.
Thank you for letting me join from my home because this is a busy session and I really appreciate it. We are talking about health occupations, clinical graduate alcohol people, or are we talking about health occupations for spouses and veterans and whatever? Which bill are we on?
The first bill, the clinical graduate alcohol drug counselors.
Great, thanks so much. So this is all about increasing the number of providers that are available to our populations. And it's really hard right now because there are not. So it's just altering the qualifications a bit. So I'm a nurse. I understand licensure really, really well. But I also know that veteran populations and family member populations have a lot of issues with both alcohol and drug use. And so, yes, we want to see more. So I represent the Maryland Military Coalition. We're 19 veteran service organizations. We are all about taking care of our service members, their families, spouses, and survivors. We completely support this bill and ask for a favorable report. It increases the number of available providers. It's done in a safe manner, and we want to see it happen. Great bill. Thank you. And thank you to our sponsor, Senator Augustine.
Thank you for your testimony. Any questions for this witness? Thank you very much for being here. That concludes the hearing on Senate Bill 14. Colleagues will now invite back up to the table Senator Augustine to present Senate Bill 101.
Okay, I think this is it for today, but I look forward to seeing you tomorrow, too.
I have a feeling we'll
All
see
right.
you tomorrow and
Yes, you
Thursday
will.
and
That's
so
right.
on and so on.
Okay, so we have here at the table Dan Martin, John Miller.
John's coming up next.
I'm sorry. Henry Harbin and Verna Little. Is that correct? Okay, all set? Very good. Well, Ann.
Yeah.
Ann's here.
yeah.
Ann's up here.
We can swap.
All right, that's fine. That's fine. Just,
Why don't you go swap?
come on up. Okay. All right, colleagues. Senator Malcolm Augustine here, Madam Chair, Madam Vice Chair here, talking about Senate Bill 101, Maryland Medical Assistance Program Collaborative Care Model Services, Implementation and Reimbursement Expansion. Colleagues, the collaborative care model is an evidence-based approach which integrates somatic and behavioral health services in primary care settings. So said a little bit differently, it's like your physical health, where you go to your primary care doctor, and making sure that's also working with your mental health, wellness, and maybe beyond, like if you have like a mental illness or things like that. And the idea is to try to have these two things all happening in one collaborative place. That's what this is all about. So it's care coordination and management. It's regular systematic monitoring and treatment using a clinical rating scale. And the regular systematic psychiatric caseload reviews and consultations for patients who do not show clinical improvement. Make sure of that. Now, studies show a reduction of psychiatric hospitalizations immediately after start of the collaborative care model implementation, especially for those with depression, as well as anxiety, PTSD, chronic pain, and dementia. There's promising evidence for the effectiveness of the collaborative care model for substance use disorders ADHD and bipolar disorders is also in progress. It's proven to be effective in improving depression for racial and ethnic minorities. And so that's in essence sort of like what the collaborative care model does. And now what does this bill do? What this bill does is it repeals the collaborative care pilot program and in its place implements and provides reimbursement for services in accordance with the collaborative care model across primary care settings under the Maryland Medical Assistance Program. Basically, we had a pilot, we're looking to make it permanent. Okay, it's been working, it's working well, we want to make it permanent. Like that's all, that's the essence of this bill, okay? So we already know from the pilot, we saw decreases for scores for both depression and anxiety for folks. Participants who completed in the pilot also a lower cost of the enrollment compared to those who did not. And so for these reasons, colleagues, I'm going to ask for a favorable report on Senate Bill 101, and then we will, if there are no questions, we can start with the panel. Thank you, Madam Chair. So first we'll hear from Dan Martin.
All right, thank you, Madam Chair, members of the committee. Dan Martin with the Mental Health Association of Maryland here in strong support of Senate Bill 101. This bill is a priority piece of legislation for the Maryland Behavioral Health Coalition this year, which comprises 100 nonprofit consumer and family advocacy organizations, peer-led groups, provider associations, hospitals, and more. And the idea is, Maryland's done a great job over the past few years in building out our behavioral health crisis response system, which is greatly needed, and those improvements should continue. But the fact is, nobody wants their first interaction with the behavioral health system to be when they're in a crisis. So the coalition's focuses attention this year on targeted community-based reforms that can improve behavioral health outcomes and save money and keep people out of crisis. And this bill is a key piece of that strategy. As Senator Augustine said, it provides Medicaid recipients with access to the collaborative care model, which is shown to improve the quality of behavioral health services delivered in primary care settings, which is where most people with mild to moderate depression and anxiety initially go to seek care. Unfortunately, behavioral health care delivered in these settings is often suboptimal, which results in higher overall costs, poor health outcomes, and increased hospitalization, and this model helps. It's a validated patient-centered approach that improves health outcomes and save money, and my panelists will talk more about what the actual model consists of in a minute. I'll just mention that commercial health insurers in Maryland and Medicare are already reimbursing for this model. And Maryland Medicaid, as Senator Augustine said, has been delivering it by a pilot program that is showing fantastic results. And so it's time to end that pilot and join the 24 other states that are providing the service broadly across their Medicaid programs. Maryland Medicaid recipients deserve access to the same proven service already available to those with commercial insurance and Medicare. And just one final note. To the fiscal note, I know it's a big fiscal note, but as you all know, these fiscal notes do not take savings into account. A quick story, Texas, just in 2021, passed its bill requiring statewide reimbursement for the collaborative care model. And initially, that bill came in with a high fiscal note. However, after reviewing implementation data from Massachusetts, the Texas Medicaid Department revised their fiscal note to 0, recognizing that the cost of providing these services is mostly offset by decreased hospitalization and higher service levels. And so if Texas can do this, we can too, and I just urge your favorable report. Thank you very much.
Hi, thank you. This is Henry Harbin. I appreciate the opportunity to present to you all. I'm a psychiatrist by background. I live in Baltimore City. I'm here representing a group called the Path Forward for Mental Health and Substance Use. It's a national group of coalition of large employers as purchasers, as well as mental health and substance abuse organizations. This group fully supports collaborative care nationally and in Maryland. You're going to hear from one of the employer representatives, John Miller, also on this panel, or next up. So I'm a psychiatrist. I've been involved in the behavioral health system for over 4 decades, and I spent 10 years in the Department of Mental Health here in Maryland. In the 1980s, I was the director of the state mental health system for several years, and I've continued to try to work on making reforms to improve delivery of mental health and substance abuse, both in Maryland and nationally. So this model of collaborative care has been recommended by every major national organization or policy recommendation since the 1999 Surgeon General's report in 1999 on mental health. We have a billing code for it. It's now being implemented across the country and in a number of medical groups here in Maryland. The important thing I think to realize is more than half of all people with a mental health social problem get all of their care in primary care, from their pediatrician, their family practitioner, and as we most know, they're very busy people. They don't have the mental health resources to fully implement the best practices, and this bill, if funded, will provide those services. Right now, Medicare nationally and in Maryland pays for this service, most all the commercial carriers, and 22 state Medicaid programs nationally. So we really, and part of why it's not being fully as implemented here in Maryland is that Medicaid doesn't pay for it fully. And so this would have a significant impact on access and quality of care for people with these illnesses.
Thank you. I appreciate the opportunity to speak. My name is Verna Little. I'm a psychologist and a social worker. I have been practicing in collaborative care for about 20 years. I have implemented hundreds of collaborative care programs nationally in every state, including Maryland. And I really just want to level for you what collaborative care is. So collaborative care is an evidence-based model to identify and treat patients with behavioral health needs in primary care settings. It is supported by over 90 randomized controlled trials, and I know that it works. I've seen it. So one of the things about bringing services to primary care is that's where people go. So we know that many people who die by suicide saw their primary care provider in the month of death. We know that more prescriptions for depression and anxiety meds are written in primary care than in specialty mental health. Collaborative care brings two people onto the primary care team. It brings a behavioral health care manager that really works with the patient over the course of a month, sometimes speaking to them multiple times. I'm a firm believer that collaborative care is actually a higher level of care for people at risk for suicide than some other models of care. Also added to the primary care team is a psychiatric consultant, and these two people work jointly to really make recommendations to the primary care providers. Collaborative care has a registry so that no patient gets left behind, so that we're working with the entire population, often 10 to 15% of a primary care provider's panel. And what that means is everyone gets care, as opposed to maybe a small number of people who get a referral and even less who actually make it to specialty mental health care. It is treat to target, and that means that we watch to make sure people are getting better, and we see a reduction in symptoms in the first months of treatment, changing the daily experience of patients. So I really encourage you to support this bill. Thank you.
Thank you very much. Question from Senator Reedy.
Thank you. I could, maybe for the sponsor, can you tell me how is this working? Like, how does this work right now, the pilot? Just, can you talk to me about where is it being done and how is it working exactly? Or anybody can answer is fine, yeah.
So there are three pilot Medicaid pilot locations right now. I believe they're spread out across the state in different kind of, areas of the state. Mm-hmm. And, those pilot locations are delivering, they were set up with the registries and all the support necessary to deliver the collaborative care model, which is described by, go ahead.
No, it's good. That's helpful. I was going to say also, that's great. So there's 3 locations right now that the pilot. So I'm Jimmy Smith, and I'm on Medicaid. I'm Medicaid, insured by Medicaid. I walk into my primary care doctor. My primary care doctor says, I say, hey, I'm experiencing these symptoms of primary care. And what happens? He sends me there. How would this work if it was scaled out? Yeah, thank you. Yeah.
So what happens is that primary care says, I work with Verna, she's part of my team. She helps me care for patients who are anxious like you talked to me about today. I'm going to have her see you today before you leave, or I'm going to have you give you a call later this afternoon, and that patient gets connected to evidence-based care right away.
So these 3 locations have partnered with doctors in the same area? Is that what's going on now?
The 3 primary care locations have partnered with individuals who can be primary care, collaborative care providers, so care managers and psychiatric consultants. So those people join the teams in these pilot primary care practices.
But they've informed the primary care doctors in the region that I'm just trying to, because we're talking about
Yes.
expanding it, it's going to be expensive. It sounds like it has great results, but, yeah, okay.
No, the primary care, there's a billing code for this, right, which is why we're trying to get Medicaid. Medicare already pays, commercials. The primary care doctors bill for this service. They're the ones that hire the care manager. And they have a virtual consultant, psychiatric consultant, that's virtual. They are part of the primary care team. So they employ these people. So this is trying to embed these mental health resources just a part of the medical team. So
Right now, if I have private insurance, I already have access to this, at least theoretically.
if the medical group is doing it,
Right.
and there are a number of them that are, but one of the reasons it's so important for Medicaid is that a number of particularly big practices in Baltimore City it's not, if 60% of your revenues are from Medicaid, it's really difficult to implement this program just for Medicare or just commercial. So
Understood. And then a final question, that we're talking, this collaborative approach, this is all about mental health. There's no other additional, this is only, you refer people out for mental health purposes with this.
Well, mental health and substance abuse both.
And substance abuse,
It's both.
mental health,
So
substance abuse.
one of the things we maybe didn't make clear, 70 to 80% of all psychiatric medications are prescribed by primary care, not by psychiatrists or other behavioral specialists. And so a lot of times primary care docs are busy. They don't have time to do the follow-up, the care management. Many primary care groups are doing this for diabetes, chronic care, they have care managers that help them. This basically provides that same care for people with depression, et cetera.
But the focus is on mental health and substance abuse.
Yes,
And it's
yes.
on treating the mental health, correct?
Right.
Okay. Thank you very much. I appreciate it. Thanks.
Thank you. Senator Lamb.
Thank you, Madam Chair, and thank you, Senator Augustine, for bringing this forward. I've heard a lot of positive feedback from providers about this collaborative care model, and it sounds like it's really working. So it's good to be able to see this really move beyond a pilot to become something that will be instituted across the state. And I couldn't agree more with what Mr. Martin was saying in terms of oftentimes the cost savings are lost in the fiscal note, right? That it only looks like an expense. And I think my question for you, and you're probably familiar with the fiscal note as well, is that just to be very clear about the fiscal implications of this, the majority of the cost of this will actually be picked up by the federal government, right? So almost 2 to 1 will be picked up by the federal government. So it's important to kind of bear that in mind when we look at that fiscal note too, beyond the cost savings that Mr. Martin pointed out that I think are very, very accurate and spot on.
Yes, I agree. Thank you, Senator.
Thank you.
Thank you. Any further questions for the sponsor or this panel? Okay, thank you very much. Thanks for your testimony. We are now, we have an Ann Geddes, Kristen Pendergrass, and Pam Casemeyer, if you want to come forward.
I'm Pam.
I was going to say.
Oh, there's Pam.
Good afternoon. Thank you, Madam Chair and committee members. My name is Ann Geddes. I'm with the Maryland Coalition of Families. MCF provides family peer support and navigation services to families who care for a child, youth, or adult with mental health or substance use needs, and I'm here in support of Senate Bill 101. Specifically, I want to address the positive impact that Senate Bill 101 would have on children and adolescents who are enrolled in Medicaid and their families. Mental health disorders affect 1 to every 4 or 5 children and adolescents, but fewer than 1/2 with a diagnosed mental health disorder receive treatment. This is partially due to the tremendous shortage of child and adolescent psychiatrists. Currently, there are some 7,000 practicing in the United States, and it's estimated that the nation requires 30,000 to adequately address the current needs. This is also due to the stigma that surrounds seeking out mental health or substance use treatment. For these reasons, children and adolescents who do receive mental health treatment are usually cared for in a primary care setting. More than 1/2 of pediatric primary care visits address mental health problems, and pediatricians write 85% of psychotropic medication prescriptions for youth. As things currently exist, this is not always ideal. Pediatric mental health conditions are frequently difficult to diagnose. They commonly co-occur with learning or developmental delays, which can be difficult to untangle. Prescribed treatment is not always effective. Pediatricians report challenges to providing quality mental health care, including lack of mental health training, insufficient time to adequately address all needs, lack of knowledge about community resources, and inadequate reimbursement. The collaborative care model, which, as has been said, is proven to be effective in improving outcomes in numerous studies across the nation, addresses all of these issues. By teaming a pediatrician with mental health specialists and closely measuring progress, mental health care in primary care settings dramatically improves. Medicare and most private insurers already reimburse for the collaborative care model. It's time that Medicaid step up and provide to its recipients the quality care that they deserve. And I was just going to add, there's been a lot in the press lately about kids languishing in emergency departments and stuck in inpatient units, needing residential level of care. This is a way to address that lower level of need before it gets so intense. Thank you.
Good. Thank you, Madam Chair and members of the committee. My name is Kristen Pendergrass. I'm the Vice President of State Policy for Shatterproof. Shatterproof is a national nonprofit dedicated to ending the addiction crisis across the country. Our three main priorities are educating, empowering communities, addressing stigma, and increasing access to quality treatment for substance use disorder, including increasing access to the collaborative care model. As you've heard, the collaborative care model is an integrative treatment model, and that it is also applicable to substance use disorder. You've also heard about the effectiveness of the model and all the evidence supporting its effectiveness. I want to call out one study from Los Angeles that found that collaborative care for opioid use disorder and alcohol use disorder increased both the proportion of patients receiving evidence-based care and the number achieving abstinence at 6 months. The collaborative care model equips primary care physicians with tools to identify and address substance use disorder early and measure treatment progress. For opioid use disorder specifically, a primary care physician may not feel comfortable prescribing medications for opioid use disorder, which are largely seen as the gold standard for treating opioid use disorder. One of these medications, buprenorphine, which as of about 2.5 weeks ago, any prescriber with a license to prescribe controlled substances can now prescribe. A primary care physician may not feel comfortable prescribing that on their own, and the collaborative care model gives them access to a psychiatrist or an addiction specialist to provide consultation or support. In addition to the health benefits of collaborative care, several studies have demonstrated that it is cost-effective. One in particular showed a return on investment of about $6.50 for every dollar invested, and this is largely due to reductions in acute care like emergency department visits. The collaborative care model has also shown to reduce disparities based on race, ethnicity, and socioeconomic status, and there's also evidence to suggest that the model leverages psychiatrists' time over 3.5 times, which is crucial given the behavioral health provider shortage across the country. One more thing, to date, 22 states provide coverage for collaborative care, and hopefully Maryland will be 23. Thank you.
Hi, Madam Chair, and members of the committee, Pam Casemeyer, and I'm actually here, excuse me, on behalf of a number of clients, the State Medical Society, the Maryland Clinical Social Worker Coalition, the Mid-Atlantic Association of Community Health Centers, and also the Academy of Pediatrics is actively watching this as well. And we're really here to say this is a pretty well-proven tool. We have the pilot project. We understand that the pilot project was supposed to go on with the final report in November. But the interim report indicated how cost-effective the pilot had been. And given its presence and use by other payers and in other states, it seemed like it doesn't make a lot of sense to slow down. If we know something we think we're going to eventually be doing, we can start earlier. And as many of you know, over the years, we've spent a lot of time focusing on medical homes and having comprehensive primary care and having people a place to go. Well, in many ways, this is almost an additional tool in the toolbox for making sure as people have their primary care provider relationships that those providers have the tools they may need or choose to use to enhance the range of screening services, issue identification that they have when they see their patients, maybe in areas where they don't necessarily do the practice. And so we think moving forward with this just makes a lot of sense. The last issue I would say is on the fiscal note, not to take away from the fiscal note, because obviously that's something everybody needs to pay attention to. but appropriately so, the fiscal note has to be written assuming every single primary care practice is going to implement this. And while we hope that happens, it doesn't mandate that it happens. It authorizes and makes sure Medicaid will cover it, should it make sense in that primary care practice to incorporate it. Thank you.
Hi, I'm John Miller. I'm Director of the Mid-Atlantic Business Group on Health. We are the local implementers of the Path Forward National Program that Henry Harbin referred to. My members are corporations largely based in Maryland, almost exclusively based in Maryland, such as McCormick Spice Company, Marriott, T. Rowe Price. Their representatives are human resource folks that arrange for health benefits for the employees and dependents that are dependent on that from the organizations. They're interested in this, and I'm interested on their behalf, not so much because of the cost issue, but because of the human issue. These human resource folks are confronted frequently with employees who come into their offices saying, I need help. I know that our mental health is covered, but I'm having very hard time getting help and support in mental health for myself or for my dependents. And these human resource folks are faced with the anguish of trying to help them get there. The collaborative care model will ease that burden, will disseminate more health care through the primary care practices where it's normally delivered, frequently delivered, and this will ease that issue. However, it is a business group, so I would be remiss if I didn't refer a little bit to the cost effectiveness of this program. Others have talked about the return on investment, so to speak, of the program. I'd like to point out that it bleeds over into physical health costs as well, that folks with behavioral health challenges frequently cost 2 to 5 times more on the medical side and surgical side. Easing the behavioral health burden will also ease the costs of physical health issues at the same time. So for us and our members, it's a no-brainer. This really should be implemented as quickly as possible. Thank you.
Thank you. Any questions for this panel? Thank you very much for your testimony. The next witness we have signed up is Rodney Koster. Going once, going twice. Okay, we have Deborah Brocato signed up in opposition to the bill. Okay. Good afternoon.
Good afternoon, Senators. I'm Deborah Brocato from Maryland Right to Life. And I'd like to say that we do appreciate the compassion that Senator Augustine has for those needing mental health services. But our opposition to this bill is that it does expand the Maryland Medical Assistance Program, and we're concerned that the funds intended for the intentions of this bill could possibly go to entities that promote and provide abortion and abortion services. So taxpayers should not be forced to fund elective abortions, and the latest Marist poll of 2023 shows that 60% of all Americans do oppose taxpayer funding of abortion and abortion services. 60% of those respondents did identify as pro-choice, so that's significant. If we look at the FY 2022 Maryland executive budget, we can see that for the years 2018, 2019, and 2020, that over $6 million was spent on about 10,000 abortions. And out of those abortions, less than 10 of those were a result of rape, sexual offense, or incest. So we can see that most of those abortions are elective abortions. Further, we know that Americans prefer that funding would be used for protecting and saving the lives of women and their children, including prioritizing funding for health and family planning services and for programs including improving maternal health and birth and delivery outcomes, baby care, parenting classes, foster care reform, and affordable adoption programs. And I would say that the funding restrictions are constitutional. Since the Dobbs versus Jackson Women's Health decision was overturned, the court did rule that the government may distinguish between abortion and other procedures in funding decisions. So we would like to see specific language excluding any funding for abortion or abortion services in this bill.
Thank you. Any questions for this witness? Okay, thank you very much for your testimony.
Thank you for your time.
We do have one virtual witness signed up, so we'll invite Sarah Frizzell. Good afternoon.
Good afternoon, and yes, you pronounced it correctly. It's a tricky one.
You can proceed.
All right, thank you. Hi, my name is Sarah Frizzell, and I am a clinical social worker in the state of Maryland, and I'm the Director of Behavioral Health Programs at PCC. We have been operating a successful collaborative care model since 2005, and I've worked in that capacity both as a direct behavioral health care manager and now overseeing the program. So PCC supports Senate Bill 101 to implement and expand reimbursement. As a provider, I've seen the impact it can have on patients' lives. I've had multiple patients tell me how important it was for them to be able to access mental health services on site at clinics where they were already comfortable, and providers being so excited to have that rather than just giving patients kind of a printout, a list of services, and then sending people on their way to find a therapist or a psychiatrist on their own. When I shared with my own primary care provider what it is I do for work, they were very envious that they did not have such a similar program. We are funded by the county government and so have not had to bill, but one of the things that we have looked at is how we spend our time. So when we look at in our collaborative care model, about 2/3 or more of our time has been spent on non-traditional behavioral health activities like case management, talking with providers, talking with our consulting psychiatrists. And so expanding Medicaid to be able to fund for these services is very important. And we're, very optimistic and hopeful that the state will support this bill. Our staff also assists when there's a crisis in the clinic, maybe a doctor encounters someone with suicidal ideation. We're often able to step in, assess, connect them to resources, and prevent unnecessary hospital visits. So in closing, just hoping that you support the expansion of funding for this program. Thank you.
Thank you. And I don't see any questions for this witness. So thank you very much. And colleagues, that will conclude the hearing on Senate Bill 101. Thank you, Senator Augustine. Good to see you. All right, we're now going to turn to Senate Bill 125, which is a business diversity incubator program. Senator Hayes, good afternoon. Come on down.
Good afternoon, Madam Chair. You mind if I call the panel up with me?
No, sure, go ahead.
At the table, I'd like for Kendrick Tillman, Michael Hunter, and Troy Stovall to join me, please. Good afternoon, Madam Chair, members of Senate Finance Committee. Senator Antonio Hayes from the 40th Legislative District. For the record, Madam Chair, this is my first time testifying in our first committee hearing in Senate Finance, so I'm still getting used to the jitters of preparing for these things. So one of the voices that I wish you had an opportunity to hear, but you will not be able to hear from today, but probably in follow-up, is Mr. Kobe Smith, who's joined us in the audience. We didn't get a chance to get him signed up in time, so you won't hear from him today, but he's a wealth of knowledge and really a huge contributor to us coming to this work product that you have before you. Senate Bill 125 establishes the Business Diversity Program in the Maryland Technology Development Corporation to provide grants to nonprofit organizations to establish diverse and effective business incubators in the state. The goal of this bill is to ensure that socially and economically disadvantaged small business owners are included in the state's procurement contracting process. In 2017-2018, only 10 of TechCo's 135 investors were made in companies run by Black entrepreneurs. This is 0.85% of the total investment amount during that time, or $270,000 out of $31 million of investment. This bill seeks to create equity in tech by addressing wide the wide chasm that exists in terms of investment into companies run by socially and economically disadvantaged individuals. As required by, and Madam Chair, you should be familiar with this, more so coming from the Budget Committee, the JCR, or the Joint Chairman's Report from 2022 General Assembly requires Maryland Technology Development Corporation, also known as TECCO, to submit a study assessing the effectiveness and impact of the state's current economic development strategy and how to elevate Marylanders who have not been included in early-stage technology opportunities. And so we as the legislature recognize the lack of diversity in this field. TECCO and its leadership have been working diligently over the last couple of years to improve these outcomes. And at the podium, at the table with me today is Troy Stovall, who serves as a leader of that organization, who could further articulate some of the successes that they've had at trying to be more inclusive. And so we have the bill before you. There are some technical amendments that need to be made to the legislation that we're working out with TECCO. We didn't have a chance to, solidify those negotiations, but before this committee is to take it up for any type of vote or whatever, those will be clear and circulated to the committee widely. Lastly, before I turn it over to our panelists, I will add that this is one of the priorities of the Legislative Black Caucus of Maryland. And with that, committee, I urge for a favorable report of Senate Bill 125 in anticipation of further amendments coming.
I'm going to last, that's fine. Good afternoon, Madam Chair, other senators of the committee. Thank you for your time today. Senator Hayes, thank you for your leadership and your team's leadership, as well as our friends at Digital Bay. This is a great example of collaboration and how the ecosystem should come together and think about how to solve this. So as Senator Hayes stated, my name is Troy Lamel Stovall. I humbly serve as the CEO of TECCO. And I just really want to read in our support of Senate Bill 125, TECCO's mission statement. Enhance economic empowerment for fostering an inclusive and entrepreneurial innovation ecosystem to identify and invest in and help grow technology companies in Maryland. That is very much what this bill is about, is how do we further include and expand those who have opportunity to entrepreneurship and innovation. So we stand ready to support this. Yes, we have a number of other programs that this will coordinate with and collaborate with. And again, thank you, Senator Hayes, and thank you all for consideration of this bill.
Good afternoon. My name is Michael Hunter. It's an honor to speak to you today about the positive impact of SB 125 and the potential to revolutionize the life sciences industry in Maryland. I'm speaking to you today as a real estate developer targeting diverse life sciences incubators. By providing lab and office space for startup companies incubated in the diverse life sciences industry, the real estate developer is helping to nurture the next generation of life science companies. I invite this panel to think big. Let's talk about the macroeconomic impact of the city and state view of this initiative. In a Baltimore City example, our collaboration can have a positive impact, for instance, on the East Baltimore community, aligning with the goals of the East Baltimore Development Initiative and contributing to the revitalization of the area. The collaboration between the real estate developer and the diverse life sciences incubator can align with the goals of the EBDI, East Baltimore Development Initiative, in several ways, by revitalizing the community, driving innovation and economic growth, fostering education and training, and supporting small business. If you think about it on the state level, we're talking about upping our ability to attract talent to the state, fostering innovation by providing a platform for the exchange of ideas and knowledge between stakeholders in the life sciences community. This kind of collaboration can help drive innovation in the field and actually bring new products and technologies to market. We also can stand to boost the state's economy, improve educational opportunities, support the growth of small business, promote diversity and inclusion, support underrepresented entrepreneurs, and encourage diversity and innovation. What's the opportunity cost of not doing this? Not supporting diverse incubators can lead to missed economic opportunities, limiting diversity and innovation, widening of the wealth gap, and missed social benefits. So I urge you to please vote in favor of SB 125. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair. I am Kendrick Tillman. I serve as the president of the Greater Baltimore Black Chamber of Commerce. And when we look at business growth through our businesses and we look at issues that can only be solved by law, that's really why I'm here. I'm an advocate today. Many of our constituents came to the chamber and said, hey, this is an issue with a lack of tech investment, and we just wanted to be proactive in working with the legislator to create a law that actually helps this issue of lack of investment. And so we just want to be here for our members of the chamber as we work with the legislator to really move this forward and seeing how we can create more incubators of color that we can really see that impact serve those underserved communities. And we have about 60 letters of support here, and we just wanted you to know that we have been doing our due diligence to reach out to constituents all around the state just to see what they thought about it, and everyone has been just so supportive. So thank you for that minute to just share some of that information.
Thank you very much. Are there questions for the senator or his panel? Okay, seeing none, thank you very much for your testimony. Good to see you, Troy. Good to see everyone. Thank you all for being here.
Thank you, Madam Chair.
We have a Trey Hayes signed up. I didn't know if there was any relation, colleague.
No relation.
No relation, okay.
He's a good brother.
Okay. Okay, good afternoon.
Good afternoon. Greetings to the distinguished members of the Finance Committee and to the Chair, Madam Griffith. My name is Trey Hayes, and I'm honored to serve as Senator Watson's Legislative Director representing the people of the 23rd District. I'm here today in support of Senate Bill 125 that will provide grants to nonprofit organizations and establish business incubators for a more diverse and equitable tech landscape in the great state of Maryland. I am the founder of GreenPage LLC, a platform that will enable Marylanders and people across the country to discover Black-owned businesses and spend their money at these storefronts. My company is in its fledgling state and has been in development for a little over a year. While our launch is closer than ever, I can only imagine where we would be today with something like the Business Diversity Program outlined in Senate Bill 125 to mentor the development of our business and guide us to funding that could kickstart our dream. This story is unfortunately not unique to GreenPage. According to Crunchbase, Black founders raised a measly $180 million in funding at the tail end of 2022, down considerably from the $500 million raised at the start of 2022, and even further from the $4.7 billion raised in 2021. This trend is grim. In total, Black founders received only $2 billion in venture capital funds in 2022, a mere fraction of the groundbreaking $160 billion raised in total in 2022. Deloitte reports nearly 8 out of 10 venture capitalist investment partners in 2020 were white, 15% were Asian, and 3% were Black. And this was in 2020, where the numbers were much more favorable. In the third quarter of last year, Black founders represented just 0.43% of the nearly $43 billion funded by venture capitalists. There is a huge gap in the venture capital industry where diversity is a unicorn, equality does not exist, and equity seems out of reach. Senate Bill 125 is an essential first step in closing this gap and rebounding from the downward trend of funding for Black-owned firms. Maryland can be a leader in paving the way for more equitable tech industry where Black faces can be seen, can thrive, and can innovate. For these reasons and more, I urge a favorable report of Senate Bill 125. Thank you.
Thank you. Are there any questions for this witness? Seeing none, thank you so much for your testimony. Colleagues, that'll conclude the hearing on Senate Bill 125.
Thank you.
We will now turn to Senate Bill 38 and invite Senator Ellis to come forward to talk about minority business enterprise procurement contract financing. Good afternoon, colleague.
Good afternoon, Chair Griffith, Vice Chair Klausmeier, colleagues on the Senate Finance Committee. For the record, I'm Arthur Ellis, Senator representing District 28, Charles County. I'm here to present Senate Bill 38, Minority Business Enterprise Procurement Contract Financing. And the purpose of this bill is to increase the amount of funds available to small businesses that have state contract to give them working capital to basically perform certain contracts. So let's imagine an electrical contractor, a small business, receive a contract to rewire this entire building. The contract, $1 million. Small business, they have the capabilities, experience, employees. That electrical contractor have to buy wires, have to pay electricians and other employees to start the work and wait until that first payment comes in from the state. A lot of small businesses don't have that kind of cash flow, money in the bank or a line of credit to perform that contract. So this bill would create a fund to help that business, fully capable, fully certified, licensed, in order to accept that contract and to finance the contract. So this is a complicated issue, and I'm working with the Attorney General's office to make it pass all the tests for constitutionality. Yesterday, I had a meeting with the Director of the Office of Equity Engagement for the Attorney General's office, Ms. Hurley, and she's working with me. In the next couple of days, we'll get the wording for amendment to change the title and to make it fit into the statutory requirement based on constitutional law to make it happen. So the title will change to, well, it'll change from, let me see, from Minority Business Enterprise Procurement Contract to Small Woman-Owned Minority Business Enterprise Contract Procurement. And also some of the language in that bill, in this bill, will also change to meet the constitutional requirement. So that is a work in progress. Could I also add that I look at the letter of information from the Maryland Department of Transportation, and they had some concerns in their letter of information, which will be addressed by the amendments that will come through from the Attorney General's office. Also, going forward, looking at the Maryland Department of Commerce's letter of information, they say a similar program exists in the state for the past 45 years and doesn't require duplication. Over that 45 years, that program has passed out around $25 million in similar help to businesses. So if you divide 25 million by 45 years, you're looking at a whopping $537,777.78 per year to help Maryland businesses. Let me say it again, $537,000 per year to help our small women-owned minority businesses. Now, that doesn't sound like tremendous help for our businesses, and we need to really readdress this issue and to be able to help our small businesses be able to compete when it comes to accepting state contracts. Because Maryland, the core of Maryland businesses, Maryland economy, is small business. And so we need to help those. And I'll move forward to issuing the financing for this bill. Initially, it was put in for using revenues from sports betting. So this bill was introduced a couple years ago, and since that time, that funding stream has been used up by the blueprint. And I have absolutely no intentions, let me say, no intention of taking money from the blueprint to do this. So we are looking at working with budget folks to address that issue. And one of the possible financing source for this fund, which is approximately $5 million a year, is the Cannabis Business Development Fund. So that will require another amendment, which is a work in progress. So we had several witnesses that attempted to sign up but were unsuccessful electronically. One of the supporters of this bill is Mr. Gaskin from the Maryland Business Clergy Partnership. and he wanted to say the Maryland Business Clergy Partnership is fully endorsing this bill. So, colleagues, I thank you for your time and your interest in helping us work this issue out, and hopefully we can get so much more help. And I tell you, as a new member of this committee and my first bill here in front of my colleagues, I thank you so much for your attention and your ability and willingness to work with me to get this done. Madam Chair, I conclude my testimony, and I ask for a favorable report on Senate Bill 38. This is my panel, sir. I just want to introduce Mr. Edsel Brown and continue, sir.
Move forward. Good afternoon, Chairwoman Griffith and members of the Finance Committee. My name is Edsel M. Brown, Jr. I live in Lusby, Maryland, and I am the chairman of the Southern Maryland Minority Chamber of Commerce, serving Calvert, Charles, St. Mary's, and Southern PG counties. I fully support Senate Bill 252. I have extensive experience working and supporting, as well as providing guidance to minority business enterprises here in Maryland, as well as around the country. In addition to currently serving as the chair of the Southern Maryland Chamber of Commerce, I have served as the assistant administrator of the U.S. Small Business Administration 8A program, chair of economic development for the Maryland NAACP, as well as a D.C.-based attorney and accredited small business consultant. In my experiences in the public, private, and nonprofit arenas, there is one common theme. Minority businesses are always in a catch-up mode with majority businesses. Access to capital is the cornerstone resource needed to move a business forward, and minority businesses lag far behind majority businesses in being able to secure it. State-based procurement contracts require contractors to have a solid financial footing and the ability to stretch capital resources into performance on a contract and the downtime in being paid for performance. Assistance and bridges must be secured to move these businesses ever forward. We must not lose sight of the fact that small businesses are the engine of the economy, and as our small businesses grow, so does the state economy. This Minority Business Enterprise Procurement Financing Program will go a long way in increasing the ability of the state's minority businesses to enter into and complete performance on contracts with the increased access to loans and grants. On behalf of the Southern Maryland Minority Chamber of Commerce, I urge you to support Senate Bill 252, and I'd be more than glad to address any questions anyone may have.
38. Excuse me? Senate Bill
Thank
38.
you so much
Okay.
for that testimony. Senator Hershey.
Thank you, Madam Chair. Colleague, welcome. Quick question on this. These are loans for working capital, is that accurate?
Yes, sir.
And who does the underwriting of the loans? Do we know what the terms would be?
Yeah, there is a agency in the Department of Commerce, and they contract with a private firm to do these loans, and the Commerce and agency will determine the terms of the loans and interest rates and when repayment will happen. So generally, repayment will happen when the state pays for the work performed.
Thank you. That was my next question. So this loan is tied to that specific contract.
Correct.
It must be payable once payment is made from the state to the contractor?
Correct.
That's the intention? Okay. In some areas of this bill, it mentions grants. Is there a difference between loans and grants?
Yeah, of course, loan requires repayment.
Right.
And a grant requires no repayment. So we give the fund the flexibility to determine which is which. And so in the bill, it also calls for the program to apply for and receive outside funding in addition to what's will be prescribed, say, funding through the cannabis sources. So if, say, they receive a federal grant, there's no reason to turn that into a loan for these businesses.
So you're saying if grant money comes into this program, then grant money could be used in this, for this working capital
Correct.
loans?
Right.
And then, is there a way that that's determined on who would be qualifying for the grant, the non-repayable grant, as opposed to a loan?
So all the businesses, small business, women-owned business, minority business, disadvantaged business will be qualified based on the terms of the grant money that comes in from the grantor.
Okay. So the grantor would be making some statements on where they'd like to see that money go?
That's usually what happens, you know, these grants are given out with some terms and conditions. And so we want to remain, the flexibility to remain in the Commerce's purview to decide, basically, based on the requirements of the grants.
Okay, fine. And finally, this is just for state contracted work?
Just for state contracted work.
Okay, thank you very much. Thank you,
welcome.
Madam Chair.
Thank you, Senator. Any additional questions for the senator or his panel? Okay, thank you very much.
Okay, thank you, Madam Chair.
We do have Deborah Brocato, who signed up in opposition to the bill. Good afternoon.
Good afternoon again, Senators. Thank you for allowing me to be here. Again, I want to commend Senator Ellis for his intentions of wanting to provide women and other minorities with the ability to start their own businesses and achieve economic prosperity. What we do object to is that money from this bill could end up being used for businesses that provide abortion and abortion services, or even possibly abortion education through like reproductive health services. So we would prefer that there would be some type of an amendment that would explicitly prohibit the use of any funds from this for any type of abortion or abortion services. As I stated before, for SB 101, taxpayers should not be forced to fund elective abortions, and the latest poll, the Marist poll, shows that 60% of Americans do oppose taxpayer funds being used for abortion or abortion services of any kind, and would prefer that they're used for helping women and children. And it would seem that it would be helpful in this bill to have an amendment like that, so that the money can definitely be directed towards services, as Senator Ellis described, like electricians and other contracts like plumbing or other vocations, and that would be such a worthy cause. Again, it is constitutional to restrict funding against things like that. So in that vein, that's why we oppose this, but we would like to see an amendment that would prohibit any kind of funds being used for abortion and abortion services. Thank you for your time today.
Thank you for your testimony. Any questions for this witness? Okay, seeing none, that concludes the hearing on Senate Bill 38. Colleagues will now turn to Senate Bill 78 and invite Senator Jackson to come forward, presenting health occupations, service members, veterans, military spouses, temporary licensure, certification, registration, and permitting. That is a long title. Good afternoon, colleague.
Thank you, Madam Chair. My first disclaimer, I did not write the title. So, good afternoon, Madam Chair, Vice Chair, members of the Senate Finance Committee. I am delegate, wow. I am nervous, right? So I think the title threw me off. So for the record, Michael Jackson, Senator representing District 27, and in my capacity as chair of the Senate Veterans Caucus on behalf of Senate Bill 78. This is a reintroduction of a bill which passed the Senate last year, which was Senate Bill 230. Senate Bill 78 would create a process requiring each health occupations board to allow for experienced healthcare professionals who also happen to be service members, military spouses, and veterans to receive temporary licensure in multiple health occupations, provided these individuals meet a few criteria. The individual must provide proof that they are a service member, a veteran, or a military spouse, having been assigned to a duty station in the state of Maryland and establish a legal residence here. The individual must provide proof that they have held a valid license or similar certification in another state for at least 1 year and be in good standing in said other state. And finally, the individual must provide proof that they have applied for full licensure, certification, registration, or permit in the state of Maryland and pay all required fees and submit the required submit to a required criminal history records check. This legislation will be applicable in numerous fields and help fill needs in a variety of healthcare professions, including audiology, dentistry, nursing, pharmacy, physical therapy, et cetera. The aim of this legislation is to create a mutually beneficial situation for both the state and for military members of their families whose service brings them to the state of Maryland. Oftentimes, as we know, as we have heard over the last couple of years, military members and their families are forced to work at levels below their expertise while seeking their certification in the state of Maryland. Among other things, this can create unnecessary financial hardships for families while individuals await their licensure and or certifications to be processed. With the need for healthcare professionals at a premium, it's imperative that we get qualified individuals to work as quickly as possible. I believe this legislation does that and helps our military. So on another note, or in other professions, allowances have been made. I can actually cite from personal experience. As the sheriff of Prince George's County, we hired folks from other states who met minimal qualifications. However, when they came to the state of Maryland, there was a list of COMAR regs or regs, as this piece of legislation is going to require folks to make sure that they are in line. So other professions have performed such acts. There's an amendment in your packet that provides some clarifying language and also creates a reporting requirement for each health occupations board. With that, Madam Chair, I would ask you and the committee for a favorable report. I believe our witnesses are virtual.
Thank you. First, let me ask if there are any questions for the sponsor. Senator Lamb, then Senator Hayes.
Thank you, Madam Chair, and thank you to the sponsor for bringing this forward. Obviously, a very important and laudable goal. I'm trying to was combing through some of the testimony from the various boards, and there's quite a bit there, and you probably have seen this as well. And we heard from briefings last week from some of the health occupations boards that many of them are facing challenges or strained already of not being able to have adequate personnel and such. And so I'm trying to figure out how to be able to help with tailoring this bill towards those applications that really, really need the help in being expedited through this. When I was going through some of the testimony from some of the other boards, many of them cite the fact that they actually already provide licenses really, really quickly. There are some boards that have some challenges, but just drawing from examples in the written testimony they provided, the acupuncture board provides licenses within 6 days. Occupational therapists say within 72 hours. The dietetic practitioners say 5 days. I think the Board of Physicians is probably fairly quickly as well. And then there were some other concerns that were brought up by some of these boards where they were concerned that it may require additional fees and may actually slow down the provision of standard licenses because they're creating a whole new mechanism and regime to be able to deal with these temporary licenses, including, if you look at the Board of Physicians testimony, more board positions would be needed, a new IT system, new application could slow down rather than accelerate things. I guess, in the context of all of that, understand the need to be able to try to get those temporary licenses out to folks sooner. Would you be open to even an amendment, for example, that would be tailored towards if a board has, say, the ability to turn these licenses around, standard licenses around, applications within 10 days or, some threshold, that they would be exempted from this requirement so that they don't generate extra work and have to potentially slow things down and increase their fees as a result of this. And some boards even say, like the social work board, say they have a licensure by endorsement, meaning that if another state, if they can point to another state that they've been licensed in for social work, that they automatically are granted a period of a couple months to be able to practice. That would give them time to be able to seek a standard license as well. Would you be open to, consideration of that?
As I've been taught over my 9 years in the legislature and probably my 20 years lobbying the legislature, the will of the body is fine with me. What I want to do is to see this come across the finish line. Look, every case has its own unique circumstances, and we're going to run into that regardless of what any piece of legislation has. And I think this gets us in a posture where we can actually begin to take closer steps or get closer to the challenges that have been created. So if the body decides that there are some amendments that you believe could help this bill get passed, then I am certainly amenable to that.
All right. I just want to be clear. I agree with the goal, really want to be supportive of it. I serve on the healthcare workforce with Senator Vital. A lot of healthcare workforce shortage issues that we want to try to address with this too. Just trying to tailor it to the boards that really need some additional help in being able to get these temporary licenses accelerated through without slowing down some of the other boards that seem to be going through these pretty quickly already.
Senator Lamb, I am in agreement with what you're saying. Look, we're not trying to create any undue burden on anyone. We're trying to get professionals where the service is needed, and this is a pool of folks who are eager and ready and willing to take care of that. And yes, I am amenable. So, thank you.
All right, thank you. Thank you, Madam Chair.
Thank you. Any other questions for the sponsor? Okay, thank you very much, Senator. We do have several witnesses signed up, and I understand they are here. The first witness I have is Ioana Stoica. How'd I do? Okay, and then we'll get Michael, thank you. We'll get Michael Tran on deck, followed by Christopher Arnold. Good afternoon.
Good afternoon, and thank you so much, Chair Griffith and Vice Chair Klausmeier, as well as members of the Finance Committee. And thank you also to Senator Jackson for introducing this important legislation. My name is Ioana Stoica, and I'm a policy advocate with the Job Opportunities Task Force, or JOTF. And we are a nonprofit organization that works to expand opportunities for employment, especially to low-income individuals, which this bill emphatically does. Some data and some background. So the Institute of Justice has ranked Maryland as the 11th most burdensome licensed state in the country. And almost 60% of our low-income residents require a license in order to work. Additionally, there was a Department of Labor study in 11 states that resulted in a report in 2020, and that study identified 3 groups of individuals that suffer the most from these type of onerous licensing laws, and one of them are our veterans and our military spouses. And so that is the issue that this bill seeks to address. Out of all of our military spouses, 39% of them, those who participate in the labor force, use a license or are licensed professionals. And a U.S. Chamber of Commerce survey additionally found that out of these individuals, 27% of them basically say that they are living paycheck to paycheck. And not only that, but they are being paid less than what other professionals who are not military or military spouses are making, and a lot of that is because they have a difficult time getting access to professional licensing. So not only would this bill do right by our veterans and our military families, but it would also contribute to addressing the racial and gender wage gap, which as the percentage of military spouses who are Black or multiracial is higher than the general population, and obviously also women constitute 90% of active duty spouses. There have been studies that show that occupational licensing laws really expand access to multiracial and also for racial and gender equity. So we urge a favorable report, and I think I'm out of time, so thank you.
Thank you. Any questions for this witness? Thank you so much for your testimony.
Thank you.
we will call Michael Tran, who will be followed by Christopher Arnold, and then Lynn Nash. You can make your way up towards the front if you're here. Good afternoon.
Good afternoon. Thank you, Madam Chair, Vice Chair, and committee members. My name is Michael Tran, Health Policy Analyst at the Maryland Board of Physicians. The board would like to thank Senator Jackson for introducing Senate Bill 78. The board is favorable to this bill with amendments. We strongly support initiatives that ensure the expedited licensure of military members, veterans, and military spouses. The board has a licensure goal of issuing 95% of licenses within 10 days of receiving a completed application. That goal has been consistently exceeded, with an average of 99% of licenses issued within that 10-day timeframe in 2019, 2020, and 2021. Data for 2022 is not available because of the tech incident last year. Military members are already expedited within the process of processing the applications at the board. That's due to the Full Employment Act of 2013. Military applications are the first to be processed and the first to be licensed once staff deem that application completed. The board has already established multiple pathways for expedited physician licensure, including participation in the Interstate Medical Licensure Compact, licensure by endorsement. Additionally, the board has introduced online application processes and licensure by uniform application. Uniform applications allow physicians to simultaneously apply for licensure in multiple states. FCVS, or the Federation of Credential Verification Services, has also been implemented to instantly verify physician credentials. The board supports Senate Bill 78. However, the board would exercise the provision to apply to the Secretary of Health for an alternate process for expedited licensure of military applicants. The board believes its current process is sufficient, and issuing a temporary license would actually slow us down. Licensure staff would have to not only process temporary licenses, but that of the regular full license. And essentially that would slow licensure down for not just military members, but for all applicants. And that concludes my testimony.
Thank you. Any questions for this witness? Thank you very much for your testimony.
Thank you.
Good afternoon. Okay, so we do have two virtual witnesses. We have first Christopher Arnold. Good afternoon.
Good afternoon, Madam Chair, esteemed committee members. The Department of Defense is grateful for the opportunity to support the policies reflected in Senate Bill 78. I am Christopher Arnold, the Mid-Atlantic Region Liaison at the DoD State Liaison Office. This legislation was passed in the past session and features many improvements for members of the uniformed services and their dependents, and I will endeavor to not repeat much of what my written testimony has already said about DoD's ongoing evaluation of license portability in the states as part of the military services strategic basing criteria. The First Lady has called military spouse licensure a national security imperative, and the department perceives interstate compacts as the optimum long-term solution to portability, an area where Maryland has unquestionably become a leader nationwide. However, as there is not a compact for every occupation, nor is every state a member of each compact, the department continues to engage states on the issue of military spouse licensure and pursue a variety of approaches to reciprocity simultaneously to fulfill our bottom line outcome to allow a military spouse to receive a license with minimal paperwork within 30 days of an application. While the bill affects a relatively small number of applicants, it is an improvement in the right direction. Many members of this committee have helped DoD resolve over a dozen licensing issues affecting military spouses in just the past 12 months. Joint Base Andrews reported onboarding delays of 3 to 12 months for the world's best trauma surgeons and military spouse physicians, which impacts readiness and retention. Regardless of a military spouse's years, it's often looked to test scores and academic records to assess competency, and military spouses who have maintained a successful career in a variety of locations and circumstances express frustration over having to justify their credibility in the same manner as a first-time applicant. The type of well-designed licensure regime in Senate Bill 78 can enhance public safety while expanding healthcare access and workforce participation. And we are grateful to you, Madam Chair, and Senator Jackson and members of the Veterans Caucus for all your hard work on this legislation.
Wow, right on time. Thank you very much for your testimony. Are there any questions? It's that discipline, that discipline. Thank you.
Roger,
very much.
I'm an Army guy, Madam Chair, so we like
Fair
to
enough, fair
handle
enough.
him effectively.
Well, we see no questions, so thank you so much for your testimony. Have a good afternoon. And colleagues, our final witness on this bill is Lynn Nash.
Thank you, Madam Chair. Apparently, I can't turn my video on. Okay, so I
There you are.
apologize. So, Captain Lynn Nash, I'm a retired 30-year nurse and now a resident of Maryland. I represent the Maryland Military Coalition, 19 organizations, 150,000 veterans here in the state. So I agree, the physicians have got their act together and they can turn a license around. However, the nursing side of the house isn't doing so well. The board's website for the Board of Nursing actually says we continue to experience delays in processing initial and renewal applications due to information technology limitations, vacant positions, and decreased operational resources. So here's my concern. 5 states allow nurses to walk up with their documentation and walk away with a temporary license. That doesn't happen in Maryland. The last time I tried to apply, it was almost 8 years. 8 months. I'm licensed in the state of Vermont. If I want a compact license, I have to go through the full kit and caboodle. And because I'm more than 1 year out from being a veteran, I don't apply for expedited. I ask that they do something about this. Please amend the bill to include veterans for more than 1 year, and please fix the process. I'm a nurse, critical care. I want to go to work. I can't. I don't have a license. So please, 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 we support with amendment to increase the time for veterans. Thank you.
Thank you so much. Are there questions for this witness? Okay, seeing none, we thank you so much for your testimony and wish you a good afternoon. Good to see you, colleague. That concludes the hearing on Senate Bill 78.
Thank you very much.
Thank you. Colleagues, our final bill of the day is Senate Bill 64, which is HIV prevention drugs, prescribing and dispensing by pharmacists and insurance requirements. Senator Lamb, and I believe your panel is virtual, so we'll get them queued up.
I think I have
Do you
one
have someone
person
here?
here in person.
Okay.
The other 2 are clinicians, and they may or may not be still available.
Okay.
We have another, I think, clinician that's on a following panel that's, I think, available, but if she's available, welcome to have her on the sponsor panel, because I think we've lost our 2 clinicians that would be testifying on this bill. Her name is
Okay.
Melanie Owusu, so I think she may be on the Zoom somewhere.
We'll see if she's in the waiting room. She's in,
So I think Matthew Langle is on the sponsor panel, and if Melanie wants to come on the sponsor panel, that would be great, too.
fantastic.
All right, so I will go ahead and begin while we work through that. So, good afternoon, members of the committee, Chair Griffith, and really pleased to be able to be here to testify on Senate Bill 64, for the record, Clarence Lamb, Senator in District 12. This bill was a bill that came before the committee last year, but was primarily assigned to former Education, Health, and Environmental Affairs Committee. It did pass the Senate unanimously last year, but ran out of time in the House. This bill is about HIV. HIV, as all of you know, is a pervasive issue, not only nationwide, but here in Maryland. At the end of 2020, there were over 31,000 people in Maryland living with HIV, and with over 700 new diagnoses in just that year, which is probably underdiagnosis because that was the year of the start of COVID. This puts us number 12 in the rank when it comes to states in the nation for diagnosis. There are large racial disparities present with diagnosis as well. Diagnosis rate being 10 times higher for Black Marylanders than white Marylanders. It also costs, and I think the costs are important to bear in mind in this because that touches on much of the bill too, an average of over $500,000 to treat HIV over the course of a patient's life if they're diagnosed. So prevention is really key to avoid that $500,000+ bill. In the last 10 years, medicine has made significant progress in the risk of transmitting HIV. There are now medications that are up to 99% effective in preventing HIV transmission. These medications are divided into two categories. The first one called pre-exposure prophylaxis, or PrEP, so PrEP is before, taken by an individual who may be at high risk of being exposed to HIV. And then there's post-exposure prophylaxis, or PEP, PEP afterwards, which is taken within 72 hours of exposure to HIV. Many folks, however, have difficulty accessing these medications for financial reasons. This may include insurance barriers, and so they're not able to, some of them may not be able to connect with a provider in the time necessary to make sure that these drugs are effective. In 2020 alone, there were over 27,000 Marylanders at high risk for HIV, but only less than 5,000 were prescribed PrEP. This amounts to just 18% of Marylanders. One significant barrier to accessing PrEP are delays related to insurance. Insurance companies commonly require prior authorization or step therapy for PrEP. And so the folks that are patients that are in need of PrEP are, by definition, at high risk of contracting HIV, and any delay in accessing PrEP can increase that risk. Insurance carriers have expressed a concern about the price difference between the two drugs that are approved for PrEP. There are two medications that currently have FDA approval, but there are certain patients for which one drug is better for certain types of patients, and we believe that providers and clinicians are best positioned to be able to make that decision over insurance companies in terms of which of the two drugs are best for which individuals. The bill also prohibits cost sharing for both PrEP and PEP related ancillary services. So there may be tests that are associated with being able to prescribe these medications by pharmacists. And under the Affordable Care Act, insurance companies are already required to cover preventive medications and care that's recommended by the federal government. PrEP and any associated care and treatment fall under federal recommendations for preventive care, and so they are fully covered by the Affordable Care Act. That includes ancillary services, the subsequent tests that come with it. But there's currently a lawsuit in Texas which seeks to carve PrEP out of the Affordable Care Act. Passing this bill will ensure that Marylanders will be able to continue to access this essential care, even if this provision of the Affordable Care Act is struck down by the federal courts. And so as a result of this case, there's a risk that without this bill, many Marylanders might not be able to afford PrEP in the future, depending on the outcome of that case. In another case in North Carolina earlier this month, HIV organizations filed discrimination complaints against insurance carriers for placing almost all HIV medications, including generic PrEP, on the highest drug tiers, making them very expensive as a result. Removing this cost sharing in this bill would eliminate any potential discrimination in copays that could be set for HIV prevention medications. California, Colorado, and Maine have already paved the way for this by removing cost sharing on both PEP and PrEP. In addition to removing insurance barriers for PrEP, the bill also expands protections in Maryland statute for PEP, which is, again, medication after someone who's been exposed to HIV would take. Last session, the General Assembly unanimously passed legislation that will prohibit prior authorization for PEP. That argument was because PEP is most effective when it's prescribed as soon as an HIV exposure is possible. So any delay following someone's exposure to HIV could reduce the effectiveness of PEP, and therefore the General Assembly last year moved forward with removing prior authorization for that. This bill expands on last year's legislation in two important ways. One, it prohibits cost sharing on PEP, post-exposure prophylaxis, which will also ensure that low-income Marylanders do not experience delays in accessing care. Currently, it doesn't matter that prior authorization is prohibited if a patient can't afford their copay. So we've eliminated prior authorization, but if they can't afford their copay, it's virtually a block on their access to care. Additionally, the bill prohibits prior authorization and cost sharing for testing that's needed for post-exposure prophylaxis, or PEP. Examples of other states that have removed prior authorization and step therapy for PrEP and PEP are the states of Maine and Nevada. Doing the same here will help ensure that we're removing any unnecessary barriers and also delays in possibly facing individuals that need these medications. In addition to codifying important insurance protections, this bill also allows pharmacists to prescribe and dispense PEP. The bill passed unanimously last year allowed pharmacists to prescribe and dispense both PrEP and PEP. And in an attempt to be responsive to MedChi's concerns, we've limited the bill this year to just PEP, not to include PrEP. This will increase the number of providers that can connect patients who are at risk of acquiring HIV with crucial preventive medication they need as quickly as possible with as few delays as possible. Pharmacists will be required to be trained to properly screen and counsel patients. That's in the bill. And if the patient does not have a primary care provider, they would be provided a list of HIV healthcare providers in the area that they're in, and also for follow-up care. All of that's written in the bill. Other states have already implemented this. California was the first state to pass legislation back in 2019, allowing pharmacists to dispense PEP and PrEP, and since then, 9 other states have followed. So in conclusion, this is a critical bill to help protect Maryland residents from a really life-devastating disease of HIV. We have good medications that would be really effective in preventing them from becoming infected, and we hope to have support with passage of this bill. Thank you, Madam Chair.
Hi, my name is Jamie Grace Alexander, and I'm here representing Free State Justice. So Free State Justice is Maryland's LGBT civil rights advocacy organization, and each year we provide free legal services to hundreds of LGBT Marylanders who could not otherwise be able to afford those legal services. And I'm here to support Senate Bill 64, which expands access to HIV prevention medications by expanding insurance coverage, limiting the ability of insurance to require pre-authorization before medication can be dispensed, and permitting pharmacists to dispense initial prescriptions of HIV prevention medications under limited circumstances. So we strongly believe that these provisions will be able to minimize the spread of HIV in Maryland. And while both PrEP and PEP dramatically decrease the risk of users contracting HIV, there are a lot of significant barriers to people gaining access to that medication. In addition to requiring a physician's prescription, PrEP and PEP often require insurance pre-authorization, and the delays brought about by these barriers can cause at-risk individuals to miss the critical 72-hour window to take post-exposure prophylaxis or miss out on the protection of PrEP before an unintentional exposure. So by limiting the ability of insurers to require pre-authorization for the use of PEP and PrEP, Senate Bill 64 ensures Marylanders will not miss out on their protection simply because they're waiting on a decision. So under SB 64, pharmacists may dispense an initial 60-day prescription of PEP or PrEP without a physician's prescription in a method similar to how Maryland pharmacists may prescribe emergency contraception behind the counter. Thank you.
Thank you. So colleagues, we have 2 additional members of the sponsor panel that we're going to bring in, Matthew Langell and Melanie Owusu. We'll bring them in, and then we'll take questions for the panel if there are any. Okay? Good afternoon.
Good afternoon. Honored to be here today to be in support of Senate Bill 64. My name is Matthew Lingle. Just a quick disclaimer, I'm testifying on my own behalf. My views are not necessarily representative of those of my employer, which is Johns Hopkins. I am a clinical pharmacy manager at our outpatient pharmacy, oversee pharmacy services in the outpatient setting and clinical programs expansion. Often the patients we're serving in our practice are underserved populations with barriers to accessing healthcare. And not only due to complexity of healthcare, but also their own social determinants of health. As we've heard, PrEP and PEP services have been shown to be more successful when they're convenient and accessible to patients and able to be started rapidly. The United States has a goal to end the HIV epidemic by 2030, which includes strategies to make sure that we're offering preventative services to patients like pre-exposure prophylaxis and also responding quickly and offering prevention services like PEP. Pharmacists are uniquely placed to increase access to both prevention and treatment for HIV management, and CDC clearly delineates them as a key professional in achieving in this goal of eliminating the epidemic. So pharmacists, as I mentioned, they're highly trained individuals that go through a doctoral degree. They provide really important access for many things and many health services. They're more accessible to patients that are not engaged in healthcare and provide convenient locations with flexible hours. I've seen personally as a pharmacist firsthand the barriers that we've seen with logistical challenges of PAs where patients were not able to get these therapies quickly. We've spent time pursuing manufacturer coupons, grant-funded programs, which all take a large amount of healthcare resources, as well as potentially disengage that patient and risk them falling out of care. Additionally, there's been some concerns about follow-up lab testing and referrals. Is what would all be a part of the procedures and policies that the pharmacists put together as part of this program, and would be very realistically possible in achieving.
Okay, thank you. You can proceed.
Hello, everyone. My name is Melanie Wusu. I am also here of my own accord. I work at University of Maryland, Midtown campus as a nurse practitioner. I also work as a nurse educator at the Mid-Atlantic AIDS Education and Training Center. So I work very, very closely with PEP and PrEP patients in my practice. So as far as PEP goes, I actually do provide that to post-sexual assault victims, but I've also met victims as people as well who may not be there necessarily for sexual assault, but they have had high-risk exposure to HIV. And there's been so many barriers that I've seen with some of these patients where they've gone from different hospitals to different hospitals and they're not able to get their medication. And when they finally do end up coming to me, it could be a matter of hours before they're out of the window of being able to get the medication in order to prevent HIV. So I'm very, very much behind this bill because as we briefly discussed, these medications could be the difference between a completely life-changing diagnosis and how someone is living their life from day to day. And in Baltimore City, where a lot of us are stationed, we know that there's already so many social disparities and things that a lot of our patients are going through. For example, in Baltimore City alone, Black men who have sex with men have a 50% lifetime chance of acquiring HIV. So if you put that and then these barriers that they're facing as far as getting the medication that they need to prevent this from happening, it can be very, very challenging for my patients, for us as clinicians. So putting it in a place where it is more accessible, like at a pharmacy, where someone can go, because we don't know when these incidents may happen. They can go at night, they can go during the day, whatever time works for them, instead of having to wait to go to a clinician or wait to go to a hospital. It's a lot easier. And then, because we all know that there's so many barriers that these patients are coming up against, it's just one less thing that they have to worry about in order to get the care that they need. And I don't think I have anything else to add, or if there's any questions as well.
Thank you very much. Are there any questions for the sponsor or the panel? Okay, seeing none, thank you very much for your testimony. Colleagues, we're going to go back to the in-person witnesses that have signed up, and then we'll go back to virtual after that. So if Sarah Price.
Thank you.
And Jawanza Reed, I probably messed that up, I apologize, are here. Good afternoon.
Good afternoon, Madam Chair and honorable members of the committee. My name is Sarah Price, and I'm here on behalf of the Maryland Association of Chain Drug Stores. I would first just like to thank Senator Lamb for bringing this forward again. We strongly agree that pharmacists are capable of providing this care and addressing the needs of some of Maryland's most vulnerable populations. The expanded hours of community pharmacy operations make them uniquely positioned to provide access to this life-saving treatment, the regimen that must be taken. It must be started within a very short window of time after exposure. You have our written testimony, and we have spoken with the senator about our position, so I'll just briefly highlight our recommended amendment to the bill. The bill as drafted would require training programs for pharmacists to cover financial assistance information, and we believe that this requirement could slow down implementation of the policy as existing programs update their content, but it could also become redundant and potentially outdated if new funding opportunities become available after a pharmacist has already undergone training. we believe that it would be more appropriate to simply require that the financial assistance information be provided to a patient by the pharmacist upon consultation. Financial assistance information and discounts are available already for so many drugs, and pharmacists, they provide this information to patients within their normal process with for dispensing everything. So they already know how to keep it up to date and available. So our recommendation would just be to streamline the maintenance of this information through the pharmacy. It'll ensure that pharmacists continue to remain up to date on what's available and keep the patients informed about what their opportunities are. Multiple other states, including our neighboring Virginia, already allow pharmacists to provide this. So we would just urge you to please consider our recommendation and bring Maryland in line with those states. Thank you.
Good afternoon, Finance Committee. I am here to communicate the Maryland Board of Pharmacy support for Senate Bill 64. HIV surveillance data compiled by the Maryland Department of Health reports that 32,149 people are living with diagnosed HIV in the state. Additionally, as of 2021, 773 new HIV diagnoses were reported. Maryland's HIV diagnosis rate is 15.5%. Senate Bill 64 proposes several interventions that may reduce the level of HIV infection in the state, specifically pharmacists prescribing and dispensing of FDA-approved post-exposure prophylaxis, commonly referred to as PEP. PEP is effective in preventing HIV infection when administered rapidly. For purposes of prevention, rapidly is within 2 hours of exposure and no later than 72 hours after exposure. Maryland's community and retail pharmacies, particularly those with extended hours, are uniquely suited to provide rapid access to PEP for the purpose of HIV prevention. Pharmacists can play an important role in ending the HIV epidemic by providing access to HIV testing, dispensing HIV reduction medications in convenient and readily accessible locations, and providing appropriate counseling and follow-up care recommendations. The board has submitted a number of amendments which were developed to more effectively implement this program, which will be discussed now. The first group is, after communicating with Senator Lamb's office, the board agrees that patients receiving PEP should be provided with a targeted list of physicians, clinics, or other healthcare providers in the area to contact regarding follow-up care. However, the board believes that the responsibility for creating and maintaining the list should rest with the Department of Health, not individual pharmacists. And the second group would be, as written, Senate Bill 64 requires a Maryland licensed pharmacist to complete additional training on the availability of PEP, and the use of post-exposure prophylaxis prior to providing access to HIV prevention medications. While the board understands that training programs are proposed to ensure that providers are properly informed, in this situation, it is unnecessary. May I have a few more moments? Okay. Currently, a pharmacist relies on their professional judgment to ensure that medications and doses are correct, prevent harmful drug interactions, and counsel patients on the safe and appropriate use of medications. In this context, a mandatory training program serves as a non-value-added barrier that some pharmacists may elect not to breach. Implementation of the program outlined in Senate Bill 64 should not be hampered by the development of unnecessary regulations and slow adoption amongst pharmacists due to duplicative training programs. The board encourages the committee to strike the training program from Senate Bill 64. And finally, the board requests a favorable report on Senate Bill 64 with the proposed amendments. Thank you.
Thank you very much. Senator Ellis.
Thank you, Madam Chair. So you threw out some numbers, ma'am, and I'm trying to follow you with the numbers. So you said diagnosis rate is 15%.
15.5%.
15.5. So how do you come up with that rate? Based on what number, what demographic group it would?
I think it's based on the total population and the new diagnoses that are reported, and that information is on the Maryland Department of Health's website, specifically under the HIV surveillance data program.
So total population of what?
Of Maryland?
Marylanders?
Yeah, of Maryland.
So 15%?
Yeah.
Of Marylanders, you're saying?
The diagnosis rate is 15.5%. That's the information that came from the Maryland Department of Health's website.
So 15% of Marylanders are diagnosed HIV?
No, there's a 15% diagnosis rate. I don't think 15% of Marylanders have.
So I'm not following that number. I don't know if...
Well, that's what I have here. I could
If you could.
get the information and send it to your office,
Yeah.
if that would
Is
be
it-
okay.
Yeah, sure. Is it like 15% of those tested, or, is there a certain population that based on? I don't think it's 15% of the population. That would be kind of high.
No, I would
So-
not think it's 15% of
so
the
I'm just
total
curious with that.
population. As it's reported on the website, it just has Maryland's HIV diagnosis rate is 15.5%.
And also, is there since you threw out the numbers, an estimate of the population that might be undiagnosed?
Yeah, these numbers do not actually include the number of individuals that are undiagnosed. I think the undiagnosed rate may be an additional 5 to 15% of the diagnosis rate.
Okay.
But there's obviously no way to tell that because the testing isn't occurring and the physicians and other healthcare providers are not making those diagnoses.
Yeah, okay. I'm not sure.
It
Sarah.
looks like Senator Lamb, did you have a follow-up on that?
Yeah, I was trying to help Elder.
Okay.
So the diagnosis rate, I think, on the website of 15% means that we're only, I think, diagnosing 15% of the people that we believe have HIV. So we're falling well short of actually testing and capturing the people that we believe have HIV out in the public, because there's inadequate testing and we're only catching 15% of them.
Thank you. That answered your question? All right, I see no further questions for this panel. Thank you very much for your testimony. We are going to now we have 3 witnesses who have signed up to testify in opposition to the bill. Kathleen Lohren, Matthew Celentano, and Deborah Rifkin. Good afternoon.
Okay.
You go. No, you go.
Good afternoon, Madam Chair, members of the Senate Finance Committee. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers of Maryland. My colleague Deb Rifkin from Care First unfortunately couldn't make it this afternoon, but is also in opposition of the bill. In many ways, we believe this bill is unneeded. PrEP is already covered by all the carriers with 0 cost share, and all the ancillary services mentioned in the bill are covered as well. This is mandated by the Federal Prevention Task Force. If anything, they will be adding services to this sort of list of things that carriers have to cover, not taking them away. One of the major concern we have from the carrier's perspective is we need to retain the prior authorization for the drugs in the PrEP space for 2 particular reasons. 1, medical appropriateness, an extra layer of protection for consumers, and 2, cost. There are really only 2 drugs in the PrEP world. There's Truvada and the associated generic, and Descovy. They are appropriate for different populations. Generic Truvada is shown to be effective for all populations. Descovy is only shown to be effective in gay and bisexual men and trans women. But it's more complicated than that. Folks with osteoporosis or kidney disease should avoid Truvada. So this is another level of protection. When the carriers get the request for the drug, we try to run down some of these particular questions. And prior auth, which is a very simple process, easily identifies the complications. I mean, I have a form in front of me that has a couple of simple questions, including one of which is, does the patient have confirmed positive HIV infection? Yes, approved, 12 months, done. It happens like that, instantaneously over the electronic system, so we don't see the delays that have been mentioned before. Also, the other portion I spoke about was the cost impact and the differences. Truvada is about $1,000 a year, and it's seen to be more effective in the general population. Descovy is $14,000 a year. It is a big difference, and it adds to premium, and it's something the carriers are particularly sensitive to. I have a lot more to talk about, but I'm sure I will get a question. So thank you very much, and I ask for an unfavorable report.
Thank you, Madam Chair, committee members. It's good to see all of you this afternoon. I'm Kathleen Loughran. I am with WellPoint, formerly known as AmeriGroup, but I am also the legislative chair of the MCO Association. There are 9 managed care organizations in the state of Maryland. We serve over 1.4 million Medicaid members, and all 9 MCOs do belong to the association. It is the association's position that this legislation is not necessary because the Medicaid program mandates coverage of both PrEP and PEP, and there are no cost-sharing or copay requirements today of our members. I can certainly talk a little bit more about efficacy and clinical and cost, but I think the simple response is this benefit's already available to Medicaid members. It's mandated by the state. As an MCO, we contract with the state, and we have to provide the benefits mandated by the program. I'd be happy to answer any questions. Thank you.
Thank you. Senator Lamb has a question.
All right, thank you, Madam Chair. Thank you to the witnesses. I do have a question, because you bring up the distinction between the two types of PrEP medications, right? And so, you know, there are important differences between those two medications, and it's not just for cis women or for trans individuals that draws that distinction. There's some important clinical differences between these two medications as well, particularly when it comes to kidney function. So, you know, from my perspective, and I'm curious as to yours, why should this decision not be left up to the individual provider to decide which medication is best for these two, for a certain individual, depending on their kidney function or other medical history?
So, Senator Lamb, thank you for that question, because I was going to get to that, but ran out of time on the clock. So, thank you for bringing it up. So osteoporosis and kidney disease are two of the factors that should be decided when going into the drug clinical effectiveness. And like Senator Lamb suggested, kidney function is one of those ways where it says you should be on Descovy, the brand name drug, and not on Truvada, the generic form. On the prior auth form, this is one of the things we talk about. Is the patient at risk for low bone mineral density, osteoporosis, osteopenia, or kidney function issues? If so, then approve immediately, 12 months, Descovy. So it's another level of protection to make sure that the proper people are getting the right drugs, but also keeping in mind that these drugs have a vastly different price tag, and it leads to increased premium for everybody. I mean, one thing I'd like to point out, especially for the benefit of this committee, is over 10 years ago, in your premium spend, it was about 7 to 8% of your premium went to prescription drugs. In less than a decade, it has spiked to over 30%. We are seeing the world on fire in prescription drug pricing, and this is one of the areas we have to pay attention to if we're going to continue the efforts that this committee has made for now a decade to really respect consumer affordability. And if we're going to keep offering products that people can get to make sure they have the peace of mind of health insurance, we have to keep some of these cost drivers in mind.
And I understand the affordability concern. You know, I think there is a difference between the cost of these medications,
Sure.
but I think that's where the provider really needs to look at the person's medical history and their individual experience with that patient to be able to decide what's best for them without needing to jump through these additional hoops in a drug that has a very tight turnaround time for administration. You know, and I understand that some of the insurers may be able to turn this around very quickly in the example that you just gave. Are you able to commit that all of your members are able to turn it around the same day?
So, Senator Lamb, this General Assembly, I want to say 8 or 9 years ago, required that all insurance carriers had electronic systems to work through these kinds of prior authorizations. Unfortunately, we did not mandate that doctors do it, so we still get faxes. But also in the Maryland statute, we have to turn around a prior auth on an emergency drug in less than 24 hours. I don't think we're going to be able to do much better with that until doctors get in the system and get some skin in the game to make sure that these electronic transactions are happening instantaneously. The take-up has been better recently, but it's still not where we need to be.
So when it comes to that question, then, can you commit that all of your members would turn this around within 24 hours if they're using the electronic system?
They're statutorily obligated with an emergency drug at under 24 hours to turn around a prior auth request.
I'm just not sure that they're able to kind of respond to that as quickly, and to the concern of overruling the provider, there really are some clinical differences here that I think lie in a concern of the insurer overruling the provider. In many instances, we really need real time to be able to turn this around. Otherwise, the moment the person walks out the door of the clinic, you know, it's going to be hard to get them back.
Well, I agree. Senator, we obviously want speed to be here, and that's why carriers over the years have developed tools like the real-time benefit checker, where in an office, a doctor can enter in the drug they're looking for and bring up the individual's insurance policy and see all the formularies where they can go and make decisions from there. The other thing that we see as crucial for prior auth is that it's care management, right? So you might be going to multiple doctors, and the one doctor might not have the benefit of seeing all the medical records from all the different doctors you're going to. The carrier, because of the the claims system has access to that. So the prior auth system is able to go through all your claims history across all the different doctors and find if there is a drug that's interacting with another one that might be problematic, it might not be safe for you. And that's the other real, highlight of what a prior auth system can do.
The other question that I had concerns the Texas case that I brought up, which was
Sure.
a lawsuit to carve PrEP out of the Affordable Care Act. And that's working its way currently through the federal courts. I think you're probably aware of that or have heard of this case. So depending on the outcome of that federal case, it could carve PrEP out, which means that there could be cost share elements introduced and greater barriers being imposed on access to these medications. Would you be supportive of parts of the bill that codify these protections, since it's already in place by the Affordable Care Act currently?
So I'd have to talk to the national teams of the carriers to find out what they think about the Texas case and what the potential is. But I will say that it is not going out on a ledge to say that Texas and Maryland are different political landscapes. Texas was the state that sued to overturn the ACA, and in this committee room, we codified the ACA. So I think it's a little different calculus between Texas and Maryland.
But that brings up a good example. This is very analogous. The Texas case is a federal case, and so there is real risk that if the federal case goes through with the outcome that would be detrimental to people being able to get access to these medications, that would impact Maryland too.
I would think
And in this
Maryland-
regard, this
yeah.
bill would be similar to the bill that you cited, codifying the Affordable Care Act protections in the state of Maryland. This would be codifying those same protections in the state of Maryland for PrEP.
I agree that it would be important to have a discussion about what would happen if the Texas federal case were to move forward, but I believe, like I said before, that Maryland carriers are already covering these things, are covering the drugs and the ancillary services at no cost share, and I can't see a reason why they would stop doing that.
Which also, I don't see why would they be opposed to then allowing this?
Well,
to
we
be
could have a
codified?
conversation about that, but that's a different discussion than the bill that's in front of us. It also doesn't talk about our concerns with the prior auth process and why we need it for these drugs in particular.
Okay, and the last question has to do with PEP. It's obviously extremely time sensitive when it comes
Sure.
to PEP, that the patient have access to that soon after they're exposed to HIV. Last year, the General Assembly prohibited prior authorization on PEP to ensure timely access. This bill, however, also limits cost share to patients to ensure that they aren't delayed because of costs. Do you think that for some of these patients, lack of funds for cost sharing could be a barrier to access to timely care?
I'm not sure I'm following you. The cost share in the ancillary services?
Cost sharing for
In
the
the
actual
PrEP space,
drug
there
itself.
is there's
for
no cost share
example-
for any Marylander in the PrEP space.
Well, there is a case in North Carolina where carriers have put PrEP, or PEP rather, on a very high tier
Well,
cost
that's
share.
not happening in Maryland.
So would you be opposed to codifying that?
To make no cost share on the PrEP drugs? I can't speak for my members on that particular position right now, but we're not offering, there's no cost share on any Maryland members in PEP at all right now.
Well, to the previous question then, if there's no cost sharing, I'm not sure why you would be opposed to codifying that. But if you could check with your members and get back to us, that'd be great.
Okay.
Thank you.
Thank you, Senator. I don't see any additional questions for this panel. Thank you very much for your testimony.
Thank you.
Wish a good afternoon. We do still have 2 witnesses in the virtual space. 3 witnesses in the virtual space, so we will call Stephen Weiner, Brad McElya, and Alaya Horton. Sorry if I've messed anyone's names up. Good afternoon.
Good afternoon. I guess I'm first. Can everyone hear me? Yes?
Yes, you're fine. You can proceed.
Great. My name is Steve Weiner. I am a pharmacist in Mount Vernon in Baltimore City. I own 2 independent pharmacies. Both serve indigent populations. We deal with patients who are affected by HIV infection and who could be infected or affected by HIV infection on a daily basis. The previous panel spoke well, so I will try and be brief. Let's talk about the why this is needed. It's needed because preventing HIV infection is the compassionate right thing to do. As a society, we should do that. If you want to ignore that, I can just tell you that the Medicaid program pays $3,689 for the most commonly prescribed HIV medication every month for every day of someone's life. That doesn't include the labs. It doesn't include the social work, the doctors, the mental health workers, the stress on their family. That just includes the medication. Almost $3,700 every month for the rest of the patient's life. And we have the ability to prevent it. And from the figures that other people gave, we can prevent it often in a very reasonable manner. That is almost a no-brain investment. Now, I submitted written testimony, but I'll use the rest of my time to address concerns. Well, there's no time. But if I could have just a hair of leeway, the nursing board's concerns, the concerns from most of the written testimony, really, there are lots of problems. There's no suggested solutions. One of the problems was a no central database. That's not correct. Legislation passed last year said all prescription drugs will have to be put in a database.
Mr. Weiner, you're going to have to wrap it up, please.
Okay. Well, there will be a database. That was the nursing concern. The other concern is pharmacists have had training with COVID vaccines, COVID treatment, and Paxlovid. And we're doing it. On an EUA, we've saved the community. And we've done everything that's in those concerns. If you look, we're doing it now for COVID.
Okay.
So why can't we do it for this? Obviously we can. Epic Pharmacies and I support this legislation and recommend a favorable opinion. Thank you for bearing with me.
Thank you. We thank you so much for your testimony. Any questions for this witness? Okay, thank you very much. Enjoy the rest of your afternoon. We'll move on. Good afternoon, sir.
Hi, distinguished members of this committee. My name is Brad McEllier, pharmacist and director of Specialty Health Solutions for Walgreens. In my opinion, the main purpose of this bill is to increase trusted and convenient access to critical HIV preventative services. Based on my experience as a pharmacist and director responsible for HIV treatment and prevention services for Walgreens, I've clearly seen that lack of access is one of, if not the largest, barriers to utilization of HIV prevention services. Through my experience in healthcare, I have seen several critical ways in which pharmacists can provide better access to people in need of HIV prevention services. First, pharmacists are embedded within nearly every community in the United States. Pharmacists are some of the most accessible healthcare professionals for individuals and provide tremendous convenience for patients. Specifically, pharmacists who have been trained in caring for those at risk of acquiring HIV who are embedded in an individual's community provide a greater level of healthcare accessibility and can even help reduce perceived stigma for individuals living with or those that at risk of acquiring HIV. Next, pharmacies have expanded operating hours where services can be convenient for all individuals. Many patients may not be able to access service for HIV prevention service in traditional settings due to operating hour limitations. Providing highly trusted, skilled, and accessible healthcare professionals with the opportunity to provide HIV preventative services will prove to be a critical component in helping to end the HIV epidemic. To that end, I also support the proposed amendment to remove financial assistance information from training program criteria so that credentialed pharmacists can begin offering this service as soon as possible. Thank you for your consideration and for your time.
Thank you very much for your testimony. Are there any questions? Senator Kramer.
Thank you, Madam Chair. And my question is, are you with Walgreens? Is that you're representing the company here? Is that...
I'm speaking as an individual, but I do work for Walgreens.
And I completely agree with everything you were saying about the professionalism of our pharmacists, which then begs the question, why are the pharmacy chains not freeing up the pharmacists to do the things they have been trained to do as professionals by increasing the numbers of assistants for the pharmacists, to put people at the cash registers so that pharmacists are not in a position where they're ringing up sales of notebook paper and other things that people are shopping for, so that the pharmacists can concentrate on what it is they have been trained and educated to do, and to be able to fulfill the needs that you are here advocating that pharmacists should be doing. Why are our pharmacies not giving them the respect to do their job?
Senator, I can't speak to all of Walgreens and all of the plans in place to free up pharmacists' time to be able to do those. I can tell you that we do have numerous different plans in place that are freeing up pharmacists' capacity to be able to provide greater care, such as even with COVID testing, COVID vaccinations and things like that. And so there are multiple different endeavors in place that are helping our pharmacists to be able to do that. But I can't speak to all of the different services that may be in place to free up the pharmacists.
Well, I think until the pharmacy industry is prepared to put a little bit of additional investment instead of squeezing out every nickel that they can, and ensure that the pharmacists are in a position to do their job, it seems a little bit as though there's a lack of sincerity when you come to the committee and say, let's, trust in our pharmacists to do the following, which I do believe they have the skill set to do, but that the industry as a whole is not providing them that opportunity. And I'll share with you, I get complaints routinely from pharmacists working at the big chains about all of the demands that are made of them beyond what it is they were trained to do, as well as constituents who stand in long lines waiting to access a pharmacist because the pharmacist is busy answering telephone calls and running over to drive-through windows and doing all of the things that others should be employed to do. So with that, I thank you, appreciate your testimony. Thank you, Madam Chair.
Thank you, Senator. I see no further questions for this witness, so we thank you so much for your testimony. And for our final witness of the day, good afternoon.
Hi, good afternoon. My name is Aaliyah Horton. I am the Executive Director of the Maryland Pharmacists Association. We are the professional society for pharmacists, pharmacy technicians, and student pharmacists in the state of Maryland, and we are in support of this bill with amendment. We do believe we are very supportive of increasing access to HIV prevention medications in pharmacies that are accessible and stigma-free. And I do appreciate the comments from Senator Kramer because that tees up actually what I wanted to speak to. I do support the comments from the previous presenters, I'll just use that, in support of the bill. But the issue that I would like to raise is that we need to include language in this bill that reimburses pharmacists for the time that they will take to prescribe and initiate this medication and treatment. That's testing, that's counseling, that's follow-up. In other health professions, it's assumed that the payers will cover it, Medicaid and commercial payers. In pharmacy, that's not required. And we want to make sure that, that they're covered. There's precedent passed by the General Assembly for when pharmacist scope is advanced or changed beyond the dispensing, that payment is required for those services. A challenge in the pharmacy environment is that we continue to build out these responsibilities for pharmacists, but they're not getting paid for those services in many cases. And that creates a tension in terms of managing the workforce. And so we want to make sure that the workforce is supported and that they're reimbursed for the time as healthcare providers. And so I offer that the senator accept an amendment to ensure that pharmacists are paid for their services. And with that, we do support the bill in the broader scope. And I do have additional amendments that are in my written testimony. So thank you.
Thank you very much. Thank you for your testimony. Are there, Senator Lamb?
Thank you, Madam Chair. Just a quick clarifying question to Ms. Horton and also to Senator Kramer's line of questioning. My understanding is that most of the pharmacists that would engage in offering these services are actually ones that are associated with academic medical centers like university pharmacists or some of the independent folks, so not necessarily the chains. And that's why I think most of the folks that we had testify, as well as the written testimony that was supported, came from more academic and university pharmacists and the like. Mrs. Horton, since you have a kind of broad view of the pharmacists that are involved in this, is that your understanding too, that it's more likely those folks?
No, I think this is an opportunity for pharmacists that are practicing in the community, regardless of whether it's in an ambulatory care pharmacy, clinics, community pharmacies, whether they're independent or chain, to support this. This is something that the broad Maryland Pharmacy Coalition is in support of this bill. And there was testimony from the Maryland Association of Chain Drugstores. Steve Weiner represents independent pharmacy. I think there's broad support within the profession, but the profession needs to be paid for the work that they're doing. And I think that will be a barrier beyond the hospital systems for pharmacists to do this work in the community environment if there is not reimbursement for their services. But from the broad scale, they're very supportive.
So I don't disagree with the reimbursement being important as a provider, obviously. I think, this bill isn't trying to touch on the reimbursement piece, which I know when it comes to reimbursement and services that are being offered can get very thorny. And oftentimes we've seen legislation kind of separate the two and deal with the reimbursement piece later. This bill really is just to open the door so that these medications can be offered by pharmacists. And our understanding is that most of these are going to initially be offered by university pharmacists and probably more of the independent folks. Obviously, it's open to any pharmacist that's licensed. But more likely, the initial folks that will offer these services are probably the university folks as well. And so, and I think Mr. Wenner from the prior witness is with an independent pharmacy, and I think he obviously supports it as well. Thank you.
Could I add one comment? It's okay.
Okay, you go. Quick.
I was just going to say that the General Assembly does have precedent and that we have passed pharmacy scope advancement bills with the payment piece added into it. So that was with contraceptive prescribing, that was with the medication administration bill, as well as with the administration of maintenance injectable medications, as well as the administration of medications for sexually transmitted infections. And those have been all within the last 5 years, excuse me. And that payment piece has been in the actual piece of legislation. They have not been separate. So there's precedent.
Thank you so much. Thank you. Well, that concludes, I don't see any additional questions. So that concludes, colleagues, and we thank you for your testimony and your time. That concludes the hearing on Senate Bill 64. That includes the hearings today of the Senate Finance Committee. Thank you, members. Thank you, team. Great job with the virtual in-person thing. Give it up for Tammy. Thank you. Meeting adjourned.